talk about maybe 2 more slides on incidence and prevalence, and then return to finish our discussions on study design. And then I believe our activity today is the teaching demonstrations. And I think today we'll be able to finish through the study design and the association and causality. I really want to go through those slides. And then what I think will end up happening tomorrow is that rather than introduce a whole new kind of set of concepts about, we'll do a little bit, maybe an hour or so, on a systems science approach to looking at problems and solutions. But we'll also talk about implementation of research a bit. So I think we'll save for tomorrow talking about things like developing protocols for training, for data collection, good data collection and management practices, and protocols for data analysis. Does this sound like a good use of time for tomorrow? Is that something that you all would like to discuss more? Okay. How many of you feel very confident in the protocols you have in place for collecting data, managing data, and data analysis? You're what? You're confident what? 100% confident that
for the protocol, when we will go to the field for data collection, we should prepare the team, set up the team first. Then the team should know about the structure of questionnaire, the beginning, training, and then we go to prepare for use the questionnaire. If they understand, they answer the reliable or consistency, something like that, and we feedback again before we go to the real. And we have the code book, like the meaning or structure procedure, which step you should do. This is quite helpful for the data collection to do the field work.
And do you do quality assurance? Do you do checks, random checks on your data collectors to see how they're collecting data and to provide them feedback or retraining?
Yes. Sometimes we have like we have, if we develop the new questionnaire, something, and have the calculate by score, we have the test in the program to do the how to say, but I cannot remember, but we did. But for the borrow from other research in Lao, something, for example, WHO, physical activity, eating habits, something like that. And we have to have like the score, more than 8, something like this, can use. And other thing, if during time after we go to field, we have supervision and have to check before we go back in field.
So they have a supervisor who checks and listens. And you do, and retraining if people are making mistakes.
Yeah, we discuss and feedback. The first week, something like it, maybe during 3 months, but we have to focus on the first 2
Yeah. Okay. Okay. Is this still something I could walk through, like a study or a few studies that I've been a part of, and sort of how you think through setting up the different protocols and training and data collection and analysis and download? Would that be helpful, kind of walking through a study and all of the different components of how you implement it. Okay, I think maybe so. What'd you say? Okay. Okay, well, we'll plan on that then. We'll go through, and I know we didn't, hopefully we'll get to talk a little more, do some more identifying study designs by your research questions, taking a research question and understanding which study design is going to be best to answer it. But like I said, we'll do 2 or 3 slides here on prevalence and incidence. Oh, that's old. Don't mind this. Hold on. I have, 10 different versions of how we've talked about this. And I know I have favorites. I'm like, where's the one with the bathtub? And I found the one with the bathtub. Probably wondering what I'm talking about. I'm talking about this. Okay, so we call this the epidemiologist's bathtub. And what it's showing here is that, say you have a bathtub, all the water in the bathtub is your prevalence of a disease. The faucet that's dripping water in is incidence. It's new cases. It's adding new cases of the disease to the prevalent cases, right? As people die, they exit prevalent cases. They go down the drain in this analogy. And then some people, maybe it's very hot water, they evaporate, they're in recovery. They may be able to be an incident case again, depending on the type of disease. So if when you're in recovery, you are susceptible to becoming a case again, you can go back through the faucet as an incident case. Does this diagram make sense? Is this a helpful visualization? Is there any, I see some puzzled faces. I wonder if if you might also describe in Lao a little? For the, for just describing this, if it makes sense. Yes. Yes. Yes, so that recovery could be a case coming back to be a new incident case. But if this makes sense, where the incident cases are being added to the bath water, which are the prevalent cases.
เนี่ยเป็นตัวนี้คือเมื่อวานนี้เราได้ลงกันเลยเนาะคือเราทำเมื่อวานเกี่ยวกับเรื่องอินซิเดนต์ที่เราเรียนเมื่อวานนี้อันนี้เนี่ยการผู้ภาคของตัวที่เราเอามาเห็นให้เขาเห็นแจ้งขึ้นมาอินซิเดนต์มันเป็นตัวไหนเนาะคืออย่างตัวอย่างเราจะเปิดน้ำเกาะตัวที่น้ำมันออกมาใหม่อยู่ในเกาะมันจะเป็นอินซิเดนต์เนาะแต่ว่าตัวที่มันอยู่ในอ่างมันเป็นกิโลเรนใหม่พอมันรวมกันเลยมันตัวโทอยู่ขนาดมันเลยแต่ว่าน้ำในอ่างมันจะมีการระเหยมันเวลามันระเหยไปแล้วมันก็จะกลับคืนมาเป็นวงจรใหม่เกิดขึ้นมันก็จะมาเป็นน้ำใหม่นะให้มันใส่เพราะฉะนั้นแล้วอยู่ในอินซิเดนต์ขนาดถึงแม้ว่ามันจะไปแล้วมันกลับคืนมาเป็นถ้าก็มาเป็นนี่เป็นอินซิเดนต์คือกันเนาะตัวนี้นะคือการที่เขายกตัวอย่างว่าในแผนว่าอันนี้เนาะอันตัวนั้นน่ะพระเจ้าเป็นไปแล้วพระเจ้าปวดแล้วพระเจ้าดีแล้วและทีนี้พระเจ้ามาเป็นผู้ที่ว่าสัมผัสกับต้องเสี่ยงใหม่เพราะฉะนั้นเลยเวลาที่จะเป็นพยาธิใหม่เขาก็ถือว่าเป็นอุบัติการใหม่คือเนาะแต่รวมของในหันกันแต่ว่าคันเป็นที่บริเวณเป็นว่ามันรวมทั้งหมดเลยให้เขาจืดแต่ว่าเขาสิเอาอยู่ไหนมาเป็นตัวหารเนาะระวังความแตกต่างระวังกัน อันprevalent กับ incident คือ prevalent นั้นหมายถึงประชากรทั้งหมดเลยแต่แม่นถ้าเอามาเป็นตัวหารแต่คำเป็น incident เลยมันถ้าเอาประชากรที่มีกลุ่มที่เป็นกลุ่มเสี่ยงกว่านั้นเนาะตัวใดที่ว่าเราบ่ได้เน้นกลุ่มเสี่ยงเฮาก็บ่ได้เอาเข้ามาที่นั้นที่ว่าเป็นตัวหารเป็นการเป็นตัวหาร
Thank you. Yay.
Yeah, so I
She could do a good
all
job.
of this come from the tech.
Yes, yes, exactly. Yep. So if we think about, so prevalence is a function of both the patterns of incidence and the duration of disease. So you can look at prevalence as approximating, so you know the squiggly lines, not exactly equal, but approximate to incidence rate times the duration of the disease. So when you have something that's more of a rare disease, rare as in, you know, 12, what's it here, 12 or 13% for diabetes, but you can have a high prevalence of diabetes because the duration of diabetes is very long. So there are more incident cases coming in, but the time people spend in the bathtub is much longer, right? So prevalence will be higher, even though it's a slow drip, there aren't people evaporating out, right? So they're in the, what'd you say?
They're not recovering.
They're not recovering. I mean, some people may have controlled, but they're often not actually recovering fully from the disease.
Chronic disease.
Chronic disease, yes, yes. So, but something like a cold or a round of a case of COVID or the flu, is that a short illness or a long illness? The acute part is short, right? So how will that affect prevalence? If the faucet is pouring in, maybe during a period of time where there are a lot of COVID cases, a lot of incident cases into the bathtub, but people are recovering quickly. So the water it's not very full, it's staying low. So the prevalence would be high or low? Low. If you're gonna have a low prevalence at any point in time for COVID or a cold or the flu, because the duration, the length of the disease is very short. Does that make sense?
The PDR is it real for the population or is it concept?
I mean, it is a,
Incident rate multiplied by duration.
that's a very good question. Wait, hold on, I want to go the other direction. I think it's more of a concept, right? But don't quote me on that. I can't remember. So I'll look at
It has the wiggle.
it has the wiggle of equals. It's approximately, although you actually I think you can use it as a calculation. Let me get past the next two slides and then we'll look. Because I think you can calculate
Because I think
prevalence.
the incidence rate has duration in there already.
Yes.
And then this formula maybe should give that when duration and the duration also in there and then eliminate.
Right, yeah, so it doesn't seem like it should be. But it's conceptually, you want to think about the prevalence as being it depends upon the incidence rate and the duration of the disease. So if we think about how would prevalence be affected if you had substantial improvement in treatment for those with HIV? And we've seen this too, right? When HIV was first became an issue was when we had our first initial outbreaks across the world, was the duration of disease short or long? Go ahead, yes. It was long. Is it longer now or shorter now than when HIV was first a problem? So, sorry, yes. Is HIV duration long now or in the past? What do you think?
So, you said the number always increasing, not increasing, even, of course, HIV cannot be, treated for, represent, treated.
Sure.
Yes, but it lasts many years, so the total number of, diseased people will be increasing year by year.
Yes, excellent. So it's the people are living now with HIV for a very long time because they're able to take medications that are suppressing their viral load, and some don't even show any trace of HIV for long periods of time, and it's become like a chronic disease. And so, as you said, the more cases there are, people are living much longer, the prevalence is going up. What was it like in the 1980s and 1990s, early 1990s? Was the duration of HIV disease in a person longer or shorter than it is now? It was shorter, right? Because we didn't have ways of treating. Go ahead.
He has a question.
Yes.
Because we study about the train of dengue fever, and he would like to study about the factor associated with dengue fever. And then we would like to survey for the household survey. It's our study of feelings or incident in this case.
Are you looking for people who currently, when you survey, do you want to find people who are currently sick with dengue or who have had it?
Yeah, in the
previous. So that would be more like prevalence, but it would be the prevalence of having been exposed to dengue. Because I know very little, but you will get more sick after you've had it once, right? Is that right? Yes. So that's very important to know who's been exposed. So maybe you may describe it as the prevalence of exposure to dengue or having had dengue. I don't know exactly how you would phrase it. But because you won't be, this will be at one period in time, a cross-sectional. Yes, so then it would be a prevalence. You wouldn't know the instance unless you were following people over time.
Actually, he is not buying survey.
What's that?
He's my he's now planning to study in the risk community.
Yeah.
You see the incidence of the previous year of dengue fever. So now they are not having dengue.
Yes, but who had it in the previous year?
20, and he or she might have relapse. of
Yeah, yes.
Something like that. So in this case, I recommend him to set as incidence rather than prevalence.
Okay, so you're gonna start from you're gonna have a date. So since
Yeah.
this date in the past
Yeah.
to the
Let's
present,
say 2022,
have you had?
in the year 2022,
Mhm.
the whole year,
Yeah, okay,
something like that.
yes, so,
In this area.
yes, so it's kind of like a retrospective study where you're looking for the incident cases, the new cases that happened in 2022, but you're going and asking them now. So you're going and saying, starting in the year of January 1st, 2022 to December 31st, how many times did you get dengue, right? Because someone could maybe get it. Yes, so then you're right. Then in that case, you are looking at an incidence. You're looking at the incidence of dengue in this population in the calendar year 2022, or whatever your period of time is. Yeah.
So one household can be zero or more than one
Mhm.
case happen, and one person can have one or more than one time
Mhm.
of fever.
And then you're counting the population that you talk to,
Yep.
right? And then, so then you'll also have to, well, really, they'll all continue to be at risk, right? The whole population, because even when you recover, you're returned back into the at-risk population, correct? Yeah,
But it is clear that it's very line between the prevalence and incidence
yes,
rate.
Right.
Because that you try to predict of the incident rate based on the retrospective that we get the information from the report or something, but the total of the whole population is with at that time is exactly the same with the total population. Because that the total of population, for example, like you conduct with the one district.
No. The size will be selected based on the most prevalent, the most prevalence, well, not sure prevalence, the highest incidence area of that period, you know, for.บ้านคุณมีอยู่ได้หลายคน
well, and I think,
But I want to clarify. The point that I want to clarify that the denominator.
No, the denominator is only the risk area.
so, but it's okay, I see what you're saying.
Only the risk area.
What I think what Bob is saying is that you're gonna be counting cumulative incidents if you're taking the total population as your denominator and seeing how many incident cases, how many new cases occurred during this time period? Or are you going to do your incident rate where you're counting the person time that each person contributes? In this case, I think cumulative incidence is probably your better option.
That's the incident, right? Not
Have the incidence rate, yeah, I think it depends on what's your plan to do with it.
The denominator, not about the time. But
It's about the
not
population.
the length of time, of course, the same length of time. But the incidence is also by time, not by person. And the denominator is also the total community members in risk areas.
The population in the risk area for the year 2022. Or whatever your time period is. Okay, then that's, yeah, you'll have cumulative incidents, yes. And that's fine for you.
What's the gray line? I don't understand what's the gray line.
Because at the beginning that I'm not quite sure about your denominator. So I thought that you will use the total of the whole population of one district. But this time that you clarify only that you will collect the incident cases in the risk site.
And then are you going
To
to,
be honest, I agree with
Do you-
you.
How you
do you plan to compare it to a lower risk or anything? Or are you trying to get the information for allocating resources? What's the goal? Just want to count?
We will look into several factors. In community,
So you're looking for factors associated.
yeah, for those for household who doesn't have dengue and household who have dengue cases occur. So
Will you-
so the comparison will be by household.
And will you be asking people if they had it previous to 2022? So you'll have essentially number of new. I'll write this, it's usually easier to read. Did I spell dengue right? Is how you spell dengue?
yeah.
Yeah, okay. Over. Because, and you're saying too, that everyone in this at-risk area is at risk, right? There's nobody that, there's no one excluded. There's no one who's not at risk for dengue, right? Okay, so this will be your cumulative incidence. And this will be total population. And what you'll end up wanting to do probably is just to, what's the estimated population in this area? How many people live there?
I don't know.
100, 1,000, 10,000,
100,
one village?
but estimate like
I'm just trying to demonstrate that you'll want to standardize it to maybe, you know, per 1,000 people maybe, or depending on how big your population is, okay? And then if you do this too, and you probably have province level estimates of instance of dengue, right? At the province or region or, I know I've looked online and seen the number of new cases of dengue and Vientiane, so this information is available, yes? These data?
these informations available on the internet.
So depending on what you should standardize it against whatever the population is that's used in regional estimates or national estimates, and then you can make a comparison too, right? So maybe 1,000 or 2,000 people, right? Whatever makes sense so that you can compare. If you want to, yeah, province. Province, region, country, other villages, whatever it is, you just want to standardize it, standardize your denominator. And then you're gonna look at some risk factors that are associated with this, right? Including having had dengue before. Wait, I mean, I don't know if this is your exact time frame, but you know, from January 1st to December 31st. So you just have to specify your exact time frame around when you're collecting this, because this is essentially like a kind of like a little retrospective cohort. It's not really, well, I guess it is. If you're going to be comparing people who didn't get dengue with those who did. Yeah, it's a little difficult to exactly define your study design, unless I know exactly what you're doing, but you're going back in time to collect data on cumulative incidence of dengue in a time period, and then looking at risk factors and comparing those who did get dengue with those who did not. Yeah.
The other thing that I should notice for this one, that the definitions of the new cases as diagnosis by doctors or diagnosis or
Great.
report.
Great question. Are the cases of dengue self-report or diagnosed by, what's your case definition for dengue?
Oh, that's on what extent, he will do a survey in that area. And ask history, because the area will be picked up by the Center of Epidemiology. And the Center of Epidemiology have report of the individuals as well, but he will not follow the individuals. He will do a survey first, and then selecting the case and control will be embedded in that survey.
Ah, nice. Okay, so he'll ask for self-report, but it's going to be verified by the regional health.
I'm not sure if he will verify the national report or not.
Okay, but it has people's, will it have people's names or households who had dengue, or
They do.
it's the actual names of people? Okay, well, that's great, because then you're also going to be
Yes,
able.
seasonal disease and the Center of Epidemiology.
Yeah, and then that'll be a nice.
Even the hospital also.
And hospital too, because you will be able to compare self-report to diagnosis. Are there people who stay at home with dengue and never go to the hospital and don't get diagnosed? There are?
Yes. If the minor or that not say we have sometimes people they just treat by themselves. Sometimes they will be young for one time, and then they continue to treat by themselves.
Yeah,
So they notice about the size of the surveillance and things.
yeah,
In this case, that's difficult for them to identify, right? But if they want to compare, or they want to take no.
right. So what happens if you get a self-reported case of dengue that's not verifiable in the data, in the epidemiologic data? Because it could be that someone had it but was treated at home and never reported it, or they're mistaken. So have you chosen how to treat that discrepancy? So I'm not getting a response, but this is something that you should think about in planning a study like this, is that you then have to decide, how are you going to treat the cases that maybe only meet part of your case definition or are self-reported but not confirmed. And you may include those. I mean, you can justify either way. You just have to make your justification. You have to explain why you're choosing to do one over the other. So you might, if you want to be very inclusive, you might want to say, we're going to count those who said they had it, but didn't seek treatment, so they didn't end up in the system. And you may also do an analysis without those people. You can do that also, where you're saying, here's the conservative analysis, and here's an analysis assuming that those people are cases. Right.
Would it be just do a cross-sectional survey for this disease? For example, if I go in November or October.
And you just do cross-sectional.
Cross-sectional.
Then you're,
How many cases happened at that time?
right then,
Right then, yeah.
yes.
Cross-sectional.
Yep, then you're getting like a point prevalence essentially of the cases,
But
right
it's a
then.
seasonal disease.
What's that?
It is a seasonal disease.
Right. Well, so yeah, so I don't know if people get it in November or not. So no one will have it in November?
No,
Okay, well, see, I don't know that.
that's why.
So no one will have it.
That's why incidents for a year would be best.
Yes, that makes sense.
I
Yeah,
think the contextual relevance would be best to select as well in such a disease, not only just a fancy with the incidence or prevalence. So,
wait, say that again, sorry.
not, I think sometimes when students conduct a study, they might feel fascinated with the kind of design or
Hmm.
prevalence and incidence will be more interesting. But to look into the nature of the disease will be.
Yes.
In your context, you know, well.
Of course, yes,
We best select which one would be best for estimation,
right.
not just getting number and then feel proud with the number that you got in that time.
Absolutely, yes, yeah, you certainly have to know your disease context enough to know that you can't assess
Some misleading.
point prevalence of dengue with a cross-sectional survey in November because no one will have it. That doing a sort of retrospective collection of cumulative incidents over the past year is reasonable for finding who had cases that previous year. Yes, so you have to find the design that fits your research question. That is necessary. But like, as we were just discussing, there are a lot of different ways he could do a cross-sectional assessment of point prevalence
Correct.
of dengue. And it would be, I think I had, hold on,
Can we look at
is it in here? Wait, yeah, like this. So if you had, if you took cumulative incidents in 1997, so this is essentially what you all are doing. You're going back, say there's 1,000 people in this. You have how many people, if each line is a case, what's the incidence of this disease out of 1,000 in cumulative incidents in 1997? Each line is a case. Just for 1997, so the middle. Which so what is incident? What is incidence?
I think incident is B, but the time to follow up is maybe only B.
So we're just looking for how many incidences, what? What, how do we count incidents? A new case, thank you. So how many new cases?
Three.
Three, yes, 3. So it's 3 out of 1,000. Okay, it's hard, you can't see that on here, but at the top it just says 1,000. So the cumulative incidence in 1997 is 3 cases per 1,000 persons, because only 3 of those are new, happened in 1997, right?
But okay,
Yes,
but you want to you want to capture only 1 year. So that meaning your program start from January to December.
yes,
But for the A that start of the observations from the 1996 that you
right. You don't count it because it was a new case. It was a new case in 1996. Now, if we were doing prevalence, what's the prevalence in 1997?
The prevalence of 1997 is 71, 2, 3. No, because the case is that the outcome is only A and C and D, right? We can see the outcome. But for B, that you cannot see the outcome. For E, you cannot see the outcome.
But that's okay, because you don't have to worry about the outcome or how long they're there. You're just counting how many cases exist in 1997 for prevalence now. Yes.
The number of cases is divided by the total of the populations. A number of cases 1, 2, 3, 4, 5. Even if we don't know about the outcome.
Right, yes, so it's 5, actually, yes, so it's 5 per 1,000 persons. If we knew going into 1997 that person A and C had whatever this disease is, and we were looking at cumulative incidence, will we include person A and C in our denominator?
For me, that the meaning of case is the outcome already exists. Is if you calculate it, meaning that the number of people they expose to the disease.
Well, this is people who just have the disease. Prevalent cases is just people who have it.
But you don't know yet for the B, they have or they don't have, because they don't have the outcome yet.
Well, so the X means they have it. So I'm sorry, I should have explained that. No, that's a really good question, because you were looking at it as like an exposure, right? But that X is the disease. So essentially it's like X means they have the disease.
And the end of the line, that meaning they're dead.
The end of the line could be they're dead, could be they're lost to follow up. But when we're talking about the cumulative incidence or the prevalence, we're concerned with those new cases for cumulative incidence or just existing. We're not worried. Now, in 1997, now if I said in November 1997, who would not be counted in prevalent cases if you only looked in November? Yeah. Actually, let's say December, because this one's hard to see. But if I said, what is the prevalence of this disease X in December 1997, what would you say?
Only A and B that it's good, right?
Yeah, you're right.
Because that those cases.
We're only looking in December of 1997. So imagine you can only see.
Only to E and D.
Yes. Just two. So the prevalence of disease X in December 1997 would be 2. Because you'll only know of 2 cases that exist in that month. Okay. Now, as I mentioned before, if you're looking at, here, let's go to this one. I forget that you have to take the prevalent cases out of your denominator, right? So when we were looking at who's at risk for disease X in 1997? Yeah, it's the 997 people are at risk because 3 people already got the disease. Okay, so if you're looking at that cumulative incidence in all of 1997, your numerator is how many new cases in 1997? 3. Your denominator is 997, because you're only counting the people at risk. And A, C, and F aren't at risk because they already have it, or F, who knows what happened to F? F might be dead. F's gone. Okay. So it's the incident cases out of the people who are at risk at the start of your observation period. So in your old study, I think from what I know of dengue, everyone is still at risk in that period, right? So you don't have to take anyone out of the denominator, because even when you recover, you become at risk again, right? Yeah. So these are the things you have to take into consideration when you're measuring incidence, prevalence. Yeah. So I appreciate the example, because I know I did say yesterday that probably a lot of you would be doing prevalence, but that is not always true. Where did I say? What did I say? I don't remind me. What am I even saying? But yes, and especially with if you're doing cohort studies, if you're doing anything with a period of follow-up, then you're likely looking at incident cases. Okay, so let's, do you want to look at the dynamic population, or do you want to go back to study design? Yes, yes.
What is the difference between cumulative incident and normal incident?
What's the difference between what?
Cumulative incident and only incident.
Most of the time when we say incidents, we mean cumulative incidents.
Oh,
Yes.
the same thing.
Yeah. Yes. It's just cumulative incidence is being more specific, or incidence risk. So the majority of the time, if someone says incidence, they're talking about cumulative incidence or incidence risk.
Or incident rate.
And then incidence rate is usually discussed with like attack rate, or that's with the person time, right? And it's a ratio, right? But it's not exactly a percentage. It's yeah, because it's the time that people, it's the incidence as a function of time, right? Okay, the rate at which new cases of disease occur in the population at risk during a defined period. But each person has to contribute that person time, right? So I don't know that I would call it a proportion. I guess it is, because aren't all rates and ratios? No, Help me out here, Nalipa. No, hold on.
Are all rates and wages?
No, they're not. All proportions are ratios, but rates, hold on, I have a thing for this. This is where, right, so proportion, look, I have it right here. So proportions are ratios, ratios are ratios. A rate is a ratio, but a rate is not a proportion, right? Look at Kelly's laughing at me.
Ratio is by the thing on the other thing.
Yeah, ratio is just dividing a thing by another thing. Exactly.
But a proportion is like cases over everybody, for example.
Yes, it's out of a total.
Whereas like rate involves some time element.
So you can compare, you can say everyone in this room, you can say, what's the proportion of women in this room? And it's women out of the total population of people in this room. Or you can say, what's the ratio of women to men? And you take the women in this room by the men in this room, right? That's your ratio, the women over the men. But a rate-
Ratio is like a comparison, so it's
Ratio is a
different set.
Yes.
That's what you did, actually, that's exactly that.
Yes, yeah, so that is if there are this total, this is your total population. But if you're comparing one set to another set, you've taken, oh, it is men, wait, yeah, it's women and men.
The women are wearing dresses and then they
See, sometimes I'm smarter than I even, my past self is smarter than my present self. I know, thank God for past self. So this is a comparison of men, women to men. But then rate is a function of time. So how fast are you driving, right? 40, I'm not as good with the rate thing.
And we also have to
Be-
thinking like when we say something like an emissions rate,
Yes,
like that's not. It's a time bound.
it's time bound, yes, it's,
It doesn't have to be a measure, it doesn't have to be a specific time in. But it has to be like at a moment in time.
yes,
Rate
yes.
as well as being how fast. like,
Thank you. Because they're not counting on an admissions rate, they're not counting, they're not saying how many people per the total population of the hospital or per the region, they're saying how many people in a day are being,
Yeah, or in 2023.
or in 2023
Specify.
are being admitted. You just have to specify that period of time. But the period of time is the denominator versus with, say, cumulative incidents where you're specifying a period of time, but it's not the denominator. You're saying 4 out of 1,000 people for the year 2022, which is different. But even I still, can still, it's more apparent when you are looking at it and measuring it in real time to see which one you're going to need. But, and yes, okay, and rates are more of an absolute. We haven't even gotten into absolute, absolute measures versus this, hold on, which is important to talk about, but I don't know how we're gonna have, do I even have it in here? Maybe not. So absolute measures are often used to allocate resources and funding. So how much of a disease is attributable to a particular risk factor? I don't know if I have, oh, there's nothing up there. Hold on. Can show. This. It could be another, I think another topic we could explore at another point in time. How, does anyone here use absolute risk in their work. So talking about, give me an example. Where are all my examples here? Like the attributable risk, or attributable risk percent, also called etiologic fraction. You familiar with this at all? Yes? Yes? Okay,
Readable risk,
yes.
how much of risk comes from a certain source?
Yes, which is very important if you're working in like policy or allocating resources. Do I have it here? I do, okay. We are not gonna spend, I'm insisting we're not gonna spend a lot of time on this right now, but so we talk a lot about relative risk in our study designs, right? We are looking at, association between exposure and outcome. We're looking at a relative risk, which is usually a risk ratio of some sort, and it's dividing one measure of disease frequency by another, right? It's just taking the incidence of an outcome in the exposed over the incidence of the outcome in the unexposed, right? That's our relative risk. So this gives us information on the strength of an association between a risk factor and disease. But we also have absolute risks, which are like incident rate difference, cumulative incident difference, attributable risk rate. This is a whole nother kind of part of epidemiology where we're talking about information about the public health impact of an exposure. And in this, when we do this, we subtract a measure of disease frequency from another. And it's a difference. So we're already assuming our causal relationship. We do this after we already know that there is some causal relationship or we have a strong relative risk, right? Then we can say, okay, well, let's subtract the incidence rate in the unexposed from the incidence rate of the outcome in the exposed and understand how much of the incidence of this outcome is attributable to this exposure. So yes, and this can go from -1 to 1. Here's an example. So does smoking increase the risk of developing lung cancer? We know we would look at the cumulative incidence of lung cancer among smokers over the cumulative incidence of lung cancer among non-smokers, right? That's our relative risk that we've talked about the last couple of days. But if we want to know among smokers, how much excess risk of lung cancer could be prevented if the exposure were eliminated. And then you would have that incidence of lung cancer in the smokers minus the incidence of lung cancer in non-smokers. And that will give you an idea of how much excess risk is because of smoking.
Is it the same as attributable risk?
Yes, that's what it is. It's attributable risk. Yes, exactly. But this is cumulative incidence difference. It's just saying the precise term is the difference in cumulative risk versus the ratio. So you see the CIR, that's the ratio of cumulative incidence. This is the difference in cumulative incidence, but it's attributable risk.
We can do the attributable risk only for the CI. How about any other study?
We usually do it for cumulative incidents. Yeah. And part of it too is that you have to have a strong risk ratio. You have to have a strong measure of association, because otherwise you're saying, okay, look at how much excess risk could be eliminated if you eliminate this exposure, like smoking, but you have to have good confidence that that really is a strong measure of association. I'm stopping short of saying causal relationship, right? Because I'm me. But other people would say, oh, you have to have a causal relationship. But you have to have, you know, the most causal relationship you can possibly find, right?
What if you compare the risk between two populations, which is not the same which is not in the same study, but not in the same study, but just different population, same population, but different places, and same technique of study, but looking into the same issue, the same problem. And the risk might be different, and can be associated that the difference of that risk.
Yeah, that's a little tricky, because typically we're doing this from the measures that we've developed, right? So these are the measures in your study. You've looked at this and you're saying that of what you've measured, you're looking at the ratio and the difference. I think it would be, I would caution against comparing across populations, and unless you somehow knew those populations were
So in this case, we didn't have we did not use pretty much
attributable risk. Yeah, I mean, here's the thing, like, say you're doing it, let me see if I can have a good example. These are all, this entire slideshow is 138 slides. It's all stuff I cut from the modules. So you have no, like, there was so much more. I was like, God, I can't fit all of this. I thought maybe it would be in here. Let me take a look. But, you know, if you're trying to make like a policy argument, you know, I think you have to use some judgment, but I would be cautious about comparing across populations, unless it's a population you can generalize to from your study, right? Like, I'd be cautious about doing it. I'm going to leave it at that.
Okay.
Okay. Yeah, let's see. I was trying to see if I have a better, yeah, it goes into effect modifiers. I think there may be an example at one point that we can get back to. 10. How does this keep happening? It's great. Like, this was such a good discussion, because it's clear that this was something that we wanted to really get a grasp on. And I thank you for the example of your study too, because I think this is a really good, having that real life example is useful for, and so how are you describing the study design of your study? I'm curious. What's the study design?
It's just a community survey in a risk area, but embedded with case and control. Because in the same area, there might be people who, that of course, in the same area, not everyone gets sick. So someone might get sick, someone might not. So those who don't get sick might be controlled in the same environment.
So you're comparing those. Okay, let's hang on to that. Let's hang on to that.
Just a concept, but
yeah, because it may be more of a. Okay, yes, we'll hang on to that. So let's go ahead and just. We have what, a half an hour?
I think we made it with those slides.
What?
You have a lot, you still have a lot of slides, right?
Oh, we have whole topics we haven't done.
All of epidemiology.
We have all of epidemiology still. What does that mean? It's terrifying. When I hear my own voice, it's terrifying. Okay, so, yes. Going back, wait, oh, this is the wrong. Oh, that's 6.5, okay. We are sadly on 6.3 still. But I think we can burn through some of these quickly, she says, as she will continue talking endlessly on 1 or 2 slides. Back to just wrapping up our cohort study design and planning, these couple of slides that you have in your topic 6.3 just summarize the ideas about planning for each so at the end of each description of a study design, there are a few summary slides that tell you what are the measures of disease frequency and association that you can use with this study design, and this is our cohort. What are the statistical hypotheses? So this isn't your research aim and associated hypotheses. These are the statistical hypotheses. Basically, if relative risk is 1, then that means what? In your cohort study, if your relative risk is 1, what does that mean?
Happy.
Yeah, happy.
You're happy?
It's not-
Nobody has.
Nobody has anything, yes.
Nobody can get this.
Nobody can get it. I like that. I like that. That's a very positive take,
Let's go. Let's
right? So because there's no difference, right? There's no association. What did you say?
Let's go. Let's bring.
Yes. Let's move on. In analytic planning, you can plan for a multivariate regression model to do what? We're going to look at our outcome. It's typically binary, right? You have it or you don't. So what kind of regression? Likely with a binary outcome?
Logis.
Yes, logistic. And what to put in, what kinds of variables are we going to put in our regression model generally? Huh?
Okay, now.
Yes, no, 0, 1.
Well, yes, that's our outcome. We have our outcome, but what else do we have to put in our model?
You asking for the X?
Yeah, sure. What's the X?
X mean.
Okay, yes, exposure. I heard someone say exposure. So on the left side, we have to have our exposure.
Luckily,
What else?
Luckily, she doesn't say exponential.
I'd be happy with X. And then what else are we gonna include? Just in general, just conceptually. We have our exposure and our outcome in a multivariate regression model. What else are we concerned about? Huh? Yeah, sure, confounders. Potential confounders, we will have gone through we'll have gone through a process of choosing which of those are included in the model. But yes, we need our outcome, we need our exposure, and we need some covariates, some potential confounders, modifiers, whatever we are calling them, but other variables. That's what makes it multivariate, right? You can also use propensity scores. We are not going to go into propensity scores. Nalupa, are you?
Oh, good. We're just gonna.
Yeah, we're gonna. And this was actually something that after I finished my training and just after I finished my training in epidemiology, propensity scores became a much more commonly used measure, but we're going to stick with our regression modeling, which is totally legit and an excellent way of doing an analysis. So then in summarizing our bias, we talked a lot about the types of bias for cohort, practicality and use of resources, so it can be expensive to plan and implement this. In particular, because of follow-up, right? Because we have to work really, really hard to get good follow-up so that we don't have what's one of our kinds of bias that we can get with if we're not rigorous about follow-up. Do you remember? Just attrition or loss to follow-up? Yeah? Okay. But it is, and it can take a long time, depending on how long your follow-up time is, but it is very efficient. Cohort studies are efficient in that you can assess multiple exposures and outcomes. So you get kind of a lot of bang for your buck, if that phrase translates. You can get a lot. Although a cohort study can be resource intensive to set up, you get a lot out of it because you can measure multiple exposures and multiple outcomes. You have to power on one particular exposure outcome relationship, but you may be able to assess many other exposures and outcomes when you do it. But it is inefficient for rare disease outcomes. Why? Why would you not want to do a cohort study for a rare disease or outcome?
So then maybe then occur in what time?
Yeah, exactly. You could wait forever and have no incident cases of the outcome. What do we use instead for a rare outcome?
Case control.
Case control. Why?
It can discount more because we saw the case and we look and compare the exposure of it.
Yes, because you're starting with the cases. It can still be hard to identify all the cases that you need, but if you start with the cases for a rare outcome or disease, that's going to be easier than just waiting for people to develop. But a rare exposure,
We should use like.
yes. So cohorts are good for rare exposures because you can select people who've had the exposure or who may be likely to have it, right? Okay. They're very good. They provide strong evidence. They have good internal validity. And the more rigorous you are with your implementation, the even greater internal validity that you'll have. Advantages, you can calculate incidence, risk, and rates if you're doing that. Temporality, you're assessing your exposure before the outcome. Usually it's the same, by saying the same directionality as the clinical question, you're saying the exposure, you have the exposed and unexposed groups, and you're following them over time as you would when you expect a disease to develop. You can look at the exposure with many diseases, and it's good for rare exposures. All right, I think we've talked about this. Expensive, takes a while to get results. Here's some examples. You can go through and look at some of these examples. Are there longitudinal cohort studies in Lao? Are there any national or large cohort studies that follow a group of people over a long period of time?
Yes, we have a RCT project that provide your indication for the intervention group.
But this, I'm talking more about these observational studies that last for many, many years and follow people.
Yeah.
So this could be a great future goal for some of you in here. You could collaborate together.
How about the development and change, the development and adaptation of some policies and see it change over years?
So watching policy change over years? Yes.
Watching health, for example, mental health outcomes, a lot of indicators that might be a lot of negative indicators might be reducing after this policy
Yes,
launch.
yes.
Things like
So what would be the study design you would most likely use for that?
Yeah, of course. Go for it.
You could use a cohort.
Panel, maybe panel study, maybe good to follow up.
Yes, so typically you would end up using a panel study to take a different sample of the population each time, but that's representative. And then track how, in general, in the population, how health outcomes are changing. If you had a cohort, you could also see, you're following the same people, right? So you could also see how these policies are affecting them, but it's not, a cohort wouldn't be an efficient way of measuring the impact of policy change on a population.
Because we don't get into the same individuals.
Right, and there could be like so many things about those individuals that may not, that may have them react differently to, but if you're sampling a representative part of the population each time with a panel, then you do. So that's what we do in the United States is we have these panel surveys where every year they're cross-sectional, but they're taking a new sample of the population each time. And they are surveillance systems, right? They're looking at how behaviors change over time. They're looking at how risk factors change over time, how disease incidence, I suppose, and prevalence, if they're collecting actual data on who has cases now, changes over time. And we do a lot of these, like we really track, there's one called the youth risk factor, YRBFS, the youth risk behavior, I can't remember, but it's about risk behaviors in adolescents. And we track this over time, and it allows us to see, like right now in the United States, adolescents are not smoking cigarettes as much, they're not drinking as much, they're not as sexually active as much as they were 20 years ago. It's changed. And so we're able to measure this over time with these panel surveys. And the youth ones, they administer in schools. So they have a sampling scheme, but we also have them for adults. We have the BRFSS, Behavioral Risk Factor Surveillance System. Then I think I have links to those in the cross-sectional or descriptive slides. So they're a really great tool. They take a lot of money. Hence, the Health Information National Trend Survey is run out of a branch of our National Cancer Institute, and it does measure, it measures everything. It has a lot on nutrition behaviors and information, because all of that contributes to cancer outcomes, but it also measures how people get information about health, who they're talking to, where they're going for sources. And so there's a branch of our National Cancer Institute that administers this survey every year. And it may have different modules, but it's been going on for like 30 years or more. So these are great tools to establish, if you can, in your country, that should be funded, if you can get funding from the government to, yes.
I just, getting this question of paper, you just go to those websites and there's like.
Oh yeah, these are the cohort ones.
Like, yeah.
Bring part.
And yeah, these are long-term cohort, it won't show, hold on. I don't think I can show it at the same time. But there are, in the 6.3 observational, nope, or 6.2, there are all of these cross-sectional.
Yeah,
In 6.2.
Briefly about them, but I think
Okay.
we just do, like the framing hammer, the nurses health study.
But these are different than
On
what,
their website, they have all sorts of, and if you check Google Scholar, there's so many, hundreds of papers like these.
yes, although these are cohort studies, which are different than what I'm talking about with the panel studies that monitor adolescent behavior. Those are not these. Those you'll find links to in the surveillance cross-sectional descriptive. Okay. Yeah.
Like, this is this kind of idea of having this cohorts. I see this example, I think, like, these are incredibly well established.
Yeah.
Huge, almost like a machine, like enterprise that has been going on for decades. A lot of resources, like they have money, they have lots of brains,
Yes.
all working on one thing. And you know, so, okay, they might be like the top, like, 1% of cohorts and, or 0.1%, I don't know, like, but the idea, I sometimes think about this as sort of a long-term institutional type thing.
Oh, yeah.
If you're thinking about, like, in your own research area or in your own institution and you want to build something long-term, having something like this might be a great idea, but required resourcing and kind of figuring out how to maintain something over time. But it builds good evidence, it creates a sort of research infrastructure for students to work, for you to do add-on studies and things like that. And the nice thing is that people have done this in countries. And so there are protocols, there are best practices. People have already like tested and kind of learned and share that experience. There's value here.
Yeah, and it is, I mean, it's incredibly difficult to do. You have to be a well-established person in order to get the funding for these and to do. So, you know, I would love to, I've long talked about establishing a cohort, and I was actually had funding to begin this in Kentucky when I lived in the state of Kentucky, a cohort of Appalachian men and women. And I really wanted to follow in particular to look at how people's social connections change over time, but also in relation to other things. But it is hard to get, they only let people who are, you know, well-established senior professors, senior scientists to kind of begin these major cohorts. And usually it's a collaborative effort. It didn't, hold on, I was trying to let this, do you know how I switch from a window? Like if I wanted to show, it's showing my PowerPoint, but if I wanted to show internet window? No? Yeah, do you know, how would I show this? Magic. We connected. Wait, no. Okay, so I was just gonna show you, I just clicked on the nurses health study link. And so, and this is where we get a lot of our current recommendations in the United States for preventive services are based on this study. I have opinions about that. I mean, it's great, but also we need more. I think that it's good that we've established baseline recommendations for say, cancer prevention services, some of those things from this. We have to continue to do more work in those areas. But this study, I have a friend who is a part of this study because I think her mother was in the original cohort. So it takes people's children and their children's children, and they just continue to go. So this is just among of women. So it gives us a lot of information about risk factors for chronic disease for women in the United States. But you can, if you want to go to it, you can look at, for researchers, you can collaborate with them. This is out of Harvard. You can look at the questionnaires that they've used. They have a biorepository, so they have a repository of all the biological specimens that they've taken over the years. You can look at the questionnaires, and you can write papers with the data that's accessible. So anything that's funded in the United States by the government, which is most research funding, you have to provide your data publicly eventually. So all of it belongs to the people of the United States because their taxes pay for your research. So you have to make all of it publicly available. You can't keep, there's a period of time where it's embargoed, where you have it until you've written your papers, and then it's made public. So you can get some information about their data. Yeah, so you can explore these, and sorry, I'm trying to do this sideways, but you can also look at all of the publications that they've put out, right? A lot of work on breast cancer from this cohort. Okay, now I don't know, did you control P? Is that it? No. Go ahead. You don't. Thank you. Okay. I'll just do the big because that's. Oh yeah. See all my tabs. Which is fine for now. Okay, so we go back to this. We'll talk a little bit of our case controls. So when you look at our validity, they're just under cohort studies. Yes. Yes. Yes.
But it will not study that. Want to discuss about the questionnaire that we use for the cohort study, because that we have a long time of the follow-up, and mostly the cohort study is the passive exposure because that we don't do anything about our type of food.
Right.
And we set up the questionnaire for the first year, for example, what we will go out for the 5 year or 10 year. And during the time of the program, that might have another factors that some concept that confounded, it might occur during the program time. And the questionnaire at the beginning and the questionnaire at the end of the program is exactly the same. Maybe you can have more.
Yes.
And how often of the program?
That's a great question. So for the questionnaire will usually be, it will have the same questions in follow-up as baseline, but also additional questions. And it may be that you ask kind of like in modules where there'll be certain questions you might ask at 1 year, at 6 months, at 1 year, depends on the length of your cohort study for these. And I think you can actually look at their questionnaires online, but I think they will assess all kinds of potential confounders. They collect a lot of information on socioeconomic data, life changes, lifestyle changes, family. They may ask different things at different time points. So you may have a set of questions you ask at 1 year and a set of questions you ask at 4 years in these very long cohorts. For a cohort that might be a 2-year or a 1-year cohort, you can do the same thing. You'll want there's often questions you ask at baseline that you may not necessarily ask at a follow-up because you're using that more to characterize who the person is at baseline. So it depends. It depends on what your research question is and what the variables are that you want to collect. But we do tend to try to make follow-up shorter so that people will engage. And if they are long, and for some of these cohorts, people are coming in, they're coming to a hospital or someone's going to their home. They're taking blood draws at a certain period of time. Maybe it's every 5 years. I don't know what the exact timing is. And having a longer interview with the individual. And I think most of these are collected by somebody actually doing an interview with the person. There's some that are, it may be by phone or in person, but they're not asking you to fill out a survey over online or something. They want to be really rigorous and collect that data themselves. There may be some things that they ask for updates on via an online form, but not the real data that they are collecting. But you want to provide incentive too, right? So if you're sitting with someone and you're taking their blood and you're spending an hour of time with them, there should be a decent amount of an incentive paid to that person to participate. Incentives are really important to follow up in particular. And, in one, it was an RCT, but an RCT is still a cohort. We had 1 month, 4 month, and 6 month follow-up. We had an initial assessment, a longer baseline, a 1 month, a 4 month, and a 6 month. So there was an incentive, I think no incentive for the risk assessment, but the baseline, there was an incentive. Maybe it was $25 gift card we usually did gift cards to grocery stores or, and then for each follow-up, I think it was shorter, and I think it was a $10 gift card for each follow-up. But if you completed everything, then you got a bonus incentive at the end also. So that gave people the incentive not only for each follow-up survey that they did, but also to complete the study. So it's useful and important to do that, to give people a reason to come back and participate. Nilipa?
When we work in East Africa, there's a lot of poverty. And so we never give, so in that context, in the US, we give money. It's not a lot of money, but it's something nice. But in Africa, we never give money because it's too coercive.
Yeah.
In the sense that maybe there's the study is something you don't like, you don't want to do, but you really need the money, so you do it even though you don't want to do it. So you feel like nobody is forcing you, but the poverty is, it's forcing you. So we might give something like 1 kg of sugar, or a package of soap, or washing powder, something nice like that. It should not be anything that affects the study. If you're doing water sanitation hygiene and you give like a lot of soap, it will change your results.
Yeah, yes.
So, think carefully, but people really appreciate the small, even very
Yes.
small things, even like 500 grams of sugar. It's so nice, like for people who don't have an ambition, it's expensive.
Yeah,
So you have to think, and we think very carefully about what we do, but we always try to do something. And no matter what is happening with the budget, we do it.
yes. I mean, that's usually when I'm writing a grant, that's the first thing that factors into the budget is, okay, how many participants do we plan on having and what are our incentives for the participants? And yes, like Nalupa said, we have to think about that a lot too. You can't be coercive and offer a $100 gift card to a grocery store for a 15-minute telephone survey. That's a lot. So our institutional review boards, our IRBs, they check this. So they will look this over and say, is this too much? In a study I did in Appalachian, Kentucky, I gave $50 gift cards because we anticipated that our interview was going to be between an hour and an hour and a half. And they first asked about that being, is this coercive? But we discussed it with the women who lived in Appalachia, and we decided it was fine. The IRB decided it was fine. It ended up that none of the surveys took that long. So when we did actually, I had some major data loss on that study. And so we went back to some of the women to recollect the data. Many of them offered to just do it for no incentive. They were happy to provide the data again. But we did have some incentives available for people if they needed it. You have to be, and I haven't really done that before. I mean, since then, because, the whole goal was I made this software to make this network data collection easier, and it worked better than I even thought. So we didn't have to pay, but the many network surveys take an hour and a half. But also, yes, in the project I'm working on in Iraq, where the individuals were working with racial ethnic minority groups who have been just bombarded by NGOs and given like free things all the time. So our team went there and started making relationships with the community. And they said, well, what do you have for us? What do you have for us? And they said, we don't have anything. We're from the university. We just want to talk with you about this. And we want to be able to give things back to you after. So they had, 400, we had 400 survey participants, 432, no incentives, but people were interested and willing to talk to them. And there's also an agreement that we're building these botanical gardens in their communities, and they're getting these products back from the team we're including their recipes in these cookbooks. So there are things that we're providing back to the community, but not to the individual participants. And that was not a choice from my end, but a choice that the university researchers in Northern Iraq decided what was best for the community. So, and people there were really happy to talk with the university because never before had the university come and talk to community members. It's just not done there. So this was an exciting relationship for them to build. But the international NGOs would come and they'd be like, well, just give us our tractors and this kind of stuff, because that was the relationship they had grown accustomed to in the past 6 or 7 years since the Islamic State since they were freed from the Islamic State. But so it really depends, like Nalupa was saying, it depends on where you're working. It depends on the norms of the community. It depends on, do you all provide incentives here for your studies? Yes, typically.
Yep.
So, it's a lot of it depends on what some of the norms are, but there should be somebody who's overseeing, hopefully your IRB, who's saying this is okay or this is not okay. If there isn't, then that's up to you guys. Okay, for you to know when this is okay and when this is not okay. What more? You had more questions, sorry.
That probably follow-up questions that you mentioned in should be the active questions and passive report. It should be right.
It could be both,
For
yes,
example, like
yes,
the dietary, for example, we want to study about the behaviors of the adolescents.
yes,
Yeah, maybe that we want to know about the weight and gain weight,
yes,
like that. And then follow up with, and but for the follow-up questions, he should select only the main questions or the whole of the question.
I think you have to make choices about what is most important for you to measure at the different points in time. If you want to know what they're eating, you may find a tool that could make it easier, like having them take photos. Maybe you prompt them via WhatsApp 3 times a week and say, hey, or on 3 different days in a week and say, don't forget to take pictures of your food today. And then they can send them to you and you can analyze them for what they're eating. There are some apps that'll do that too. Rather than ask them to fill out a questionnaire. But you may just ask them to fill out a questionnaire and you may send it to them. Maybe you do that via WhatsApp or something where you're going to be able to get it to them quickly and prompt them to fill it out. And then you're going and interviewing maybe or collecting data in person, and you have both of those types of data. I think it's really smart to combine the types of data collection that you use for something like a cohort, because then you can have, maybe you have the biological or the anthropometric measures, and self-report and some specific things that you collect, and combine those together. But it really does, what you ask on follow-up depends on your research question and what you want to see change. If you want to see change in something, or if you're assessing your exposure at multiple points in time, then you want to probably ask those questions each time that's reasonable, right? Yeah.
That's what exactly that I have. I want to exposure for
Yeah.
And the last question is about the analysis.
Mm,
Of that we collect the data many times
yes,
during a certain time. So
yes,
But how it look like when you entry the data and you plan to do the analysis of the data?
yes. That is a great question. And I wonder if I have this,
Yeah, over.
more articles. I don't think, this is not the
Just
one.
add more variables, if you add more.
Oh, more variables. Oh, there's more articles.
No, but at the end that you sum up or what exactly you do with your data?
Yeah, no, this is a great question. I want to show you if I can find, this is the one.
First time, Q1, second time, Q1, three time, Q1 and third.
Yes, here is, let's see, I don't know if I can get,
I cannot imagine.
oh, here it is. Hold on. I think I don't have access to this, Taylor Francis, but I can go to the public access version. So here's an example of this is a study that an RCT that I worked on, but it's still, because an RCT is still a cohort study, still a longitudinal, so still a cohort study. It's just one where we intervene. What's that? Oh, referral.
of-
Yes, so that'll take a little explaining of what this is. I was gonna talk to you guys about this study. These are referrals we provided to people to for cancer prevention and control services. But this is a study where we did, sorry, I'm gonna make you dizzy. A multiple time points and multiple outcome points too. So did they remember the referrals we gave them? Did they try to contact any of them? Did they actually reach anyone at the referral? Did you get help there? And was their problem resolved? So these are some sort of intermediary outcomes that we measured that weren't the full outcome, right? And this is for problem resolution. Wait, this is not the paper I wanted to show you. This is about their 2-in-1 problem. This is not about their cancer. I will find it. I'll find this example and show you how we analyzed multiple time point. Which is the right outcomes paper. Here's this one. I'm just going to skip to the tables and see. It's just the final one. Okay, well, let me go back to this one. Sorry, I see you're trying to follow. I think we's trying to follow and I'm jumping all over the place with these papers. But so typically, let me just give you a short answer to your questions. And that is that you can look at how I told you this was a 6-month study, right? We did 1 month, 4 month, and 6 month follow-up. These are findings that we're reporting for 1 month. But then we also report findings for the 4 month and the 6 month. Ultimately, the outcome that we're powered on, that we're interested in, is that 6-month outcome. But you can look at how that outcome has progressed over time. So some people reached the outcome by month 1. Other people took until month 6. And you can analyze those separately. You can also, but ultimately your research question is essentially to analyze the final outcome, right? If you're thinking about the multiple exposures, are you thinking about measuring how exposure changes over time?
For me, I want to know about the exposures. Is the changes of their behavior. For example, like focus on the weight gain, how the exposures impact to the weight gain. For example, like they change their behavior during the time for first year or second year or third year.
Yeah.
After that, if example, Vietnam is at the beginning, we maintain at BMI like this, and for the third year, third year is it increase or decrease?
Yeah,
During why is decrease? Why is increase? That exposure changing.
yeah,
But
I think,
sometimes that might it depends the factor the converter might they have more reliable about the impact of their having overweight or obesity, and it's they're scared about the disease and the change, or maybe that people they have some interventions from other projects.
Yeah.
And
yes, yes. So you're going to have to measure all of those things. You are. And then I think what it sounds like is that your outcomes and your exposures may end up being about change. So change in exposure, and you'll have to quantify that. And then your outcome may end up being a change in weight, right? Or whatever that happens to be versus an absolute. So I think you'll have to think about how that'll be measured and expressed. And I'm happy to talk with you more about that. And I think we should involve a statistician. Lupa looked up. It would be good to involve a statistician in planning for that kind of analysis, because it may not be that tricky, but it's a little trickier than having a standard kind of binary outcome. So I think those are good measures, I think. It's just being very careful and rigorous about how you plan to do the measurement and the analysis.
For your PhD, I'll be example.
Yeah,
I'll be example.
I like it. Me too. Okay, I'm way over on time, so let's stop here. And do we need a little break before? Mhm.
สบายดีหมดทุกคนเนาะมื้อนี้ก็สิมาอ่านชื่อทีละจันทร์เต้ก็ได้เนาะราชิมาสอนเนี่ยมื้อนี้หัวข้ออยู่ในท็อปปิกในโมดูลของโมดูล6กับ7เนาะก็จะเล่าเรื่องการstatistic design แล้วก็การ planning แต่จะลงลึกคือเรื่องอะไร study planning กับการเซตอัพหรือว่าการจัดตั้งการคุ้มครองหรือว่าแผนการเช็คแผนการหลังจากพวกเรามีโปรเจกต์กันเรียบร้อยแล้วเนาะแล้วการที่ว่าเฮาสิไปลงไปเก็บข้อมูลก่อนนั้นทำทุกอย่างมันต้องมีการเฮ็ดแผนฉะนั้นแผนมันมีความสำคัญแนวใดเนาะใช่ไหมมันเป็นขั้นตอนที่สำคัญหนึ่งที่ว่าสำคัญหลายมันได้เฮ็ดให้เวลาการเฮาเฮ็ดเวียกลดพรการเวลาเฮ็ดเวียกได้ดีแล้วก็มีการ manage มีการจัดการส่งกันเวลาแล้วก็คนหรือว่าสถานที่ต่างๆเนาะและอีกอย่างหนึ่งคือมันจะช่วยให้เขาสามารถติดตามแล้วก็ช่วยให้ควบคุมในการเก็บข้อมูลให้ได้ประสิทธิภาพประสิทธิผลเนาะย้อนว่าข้อมูลของเขานี่มันแน่นอนว่าข้อมูลมันต้องสำคัญอยู่แล้วในการโปรเจกต์ของเขาทุกการเฮ็ดโปรเจกต์อันสำคัญคือข้อมูลมันต้องมีคุณภาพในการให้ถ้าการเฮ็ดวางแผนเราอีกอันหนึ่งคือเพื่อจัดการความเสี่ยงอยู่ในลิสต์เฮาบ่ให้มีไบแอสแบบจะเพิ่นได้เว้าไปก่อนหน้านี้แล้วเนาะฉะนั้น
พวกเขาที่มีการจัดการแนวใดเดียกับการแข่งขันนี้เนาะก็คือเขาที่มีการจัดการตามขั้นตอนกับคล้ายๆกับแบบว่าเขาที่เก็บแนวใดเก็บอยู่ไสเก็บกับไผแล้วก็เขาที่เก็บแนวใดแล้วเป็นอย่างเขาต้องมีอีกอันหนึ่งคือเป็นอย่างเขาคือได้เก็บแบบนี้อันนี้ก็ต้องได้เรียนต้องได้รู้โดยที่ว่าอาจจะเป็นอาจจะมีเนาะคือที่ผ่านมาเนาะอาจจะมีเฮ็ดถึงเช็คลิสต์เลยว่าเขาได้เฮ็ดอย่างเด่นเขาสิได้เฮ็ดหยังเขาได้เฮ็ดหยังแล้วเป็นไผที่เป็นคนรับผิดชอบเรียนงานต่างๆแล้วก็ให้เบิ่งว่าเฮ็ดตัวใดเฮ็ดแล้วตัวใดบ่ทันได้เฮ็ดแล้วนี่เนาะแล้วสิจัดการแนวใดอันคือทุกอย่างคือการมันแผนนี่ต้องเฮ็ดแบบง่ายดายเข้าใจแล้วก็มันต้องสอดคล้องกับสมมุติฐานบ่คำถามการค้นคว้าของเขาที่ผ่านมาและหลังจากที่ว่าเขาได้ข้อมูลเนี่ยทุกอย่างแล้วเนาะความเซฟตี้ความปลอดภัยของข้อมูลทุกอย่างนี่มันก็ต้องเบิ่งว่ามันได้มีการเก็บเนี่ยที่ดีไว้บนใดนอนมิสต์เก็บไว้บนใดการป้องกันการรักษาข้อมูลนี่ก็คือต้องเบิ่งตั้งแต่เขาได้ข้อมูลมาแล้วหลังจากผู้ data collector เนาะจะเป็นคนส่งต่อให้ผู้ที่ analysis ตัวนั้นส่งบางตัวนั้นเขาก็ต้องให้แน่ใจว่ามันข้อมูลนั้นมันมีประสิทธิภาพและมีความสมบูรณ์มีความเที่ยงตรงเนาะในการข้อมูลเพื่อที่ให้ส่งต่อให้ data analysis ท่านเป็นคนที่วิเคราะห์ข้อมูลให้มันได้ถูกต้องของโปรเจกต์ของให้ได้ตามโกลของโปรเจกต์ของเขาอันนี้ก็เป็นการจัดการการวางแผนของการเก็บข้อมูลและการนั้นจัดการโครงการก็อาจจะใช้แผนคล้ายๆแบบนี้ก็ได้ตามที่ว่ามีตัวอย่างแบบนี้อาจจะเป็นเช็คลิสต์หรือว่าเป็นคล้ายๆเป็นเวิร์กแพลนต่างๆแล้วอันนี้ก็เมื่อนี้ใจเลยเป๊ะคำถามแล้วที่โอเคมีคำถามเรา
yes เบิ่งอาจารย์การบทเรียนเป็นได้ดีสักส่วนเนาะแต่ว่าอันเป็นท่าอันนี้ก็คือว่าแต่ว่าในธรรมชาติของมัน professor university หรือว่า lecturer ได้ไปกันเนาะย้อนมาหลังเรื่องของมีหลายอย่างเขาจะบริการนักเรียนที่เขาเข้าไปทุกต่อกันเลยแล้วก็บริมีโอกาสทำเพราะว่าเขาคิดว่านักเรียนชั้นหนึ่งสิมีองค์เปิดกิจให้ยังเขาถึงทำนะแต่ส่วนแรกจะคิดได้น้องนี่แหละเนาะแต่ว่าอย่างเมื่อเราทำนักเรียนนี่คือการสอนการเรียนเขาน้องน้อยใช่คนอื่นนี่But normally when I do the research because I said, oh, they're coming and they will do exercise later. That's why I just explain and finish and go back.
Yes, it takes a lot more work to ask questions and then you have to answer them too. So yeah,
But then you should get into the
Yeah, when I am the student, so the teacher tell good plan for me, and I can understand well. The teacher to tell me you have some research, you have a project already, and you should have good plan and good data.
so she did a good job of teaching you.
I think very prepared and good example. แสดงว่าจุดนี้คือคนที่ซ่อนในที่มุทิภาพเพราะฉะนั้นถ้าเราเขียนก็มีแต่การมีแล้ว
โดย
ตรงนี้เนาะโดยสบายดีทุกท่านโดยก่อนอื่นเนาะขอให้นักเรียนตบมือกันเนาะบาทหนึ่งเนาะบาทหนึ่งบาทหนึ่งบาทหนึ่งอีกครั้งหนึ่งบาทหนึ่ง2 บาทเอาก่ายเนาะอีกบาทหนึ่ง2 บาทยังให้ความตั้งใจแล้วก็ถ้าใจมาตั้งใจฟังอยู่เนาะโดยต่อไปที่เราจะเป็นการให้ข้อมูลเบื้องต้นเกี่ยวกับการเก็บข้อมูลเนาะข้าพเจ้าเองหรือว่าอาจารย์เองมีชื่อว่าหงคำชัยวงศ์เนาะหรือสั้นๆว่าลีน่าเนาะเจ้าซึ่งว่าการเก็บข้อมูลหลายๆทางเคยจะมีประสบการณ์มาก่อนในแล้วเนาะอยากรู้ว่าในนี้ใครเข้าใจแน่ว่าการเก็บข้อมูลหมายถึงอย่าง1 2 3 4 5โดยผู้เสื้อสีม่วงโดยการเก็บกับข้อมูลโดยการเก็บกับข้อมูลหลายอย่างเขาจะให้นิยามที่บอสั้น
การเก็บกับข้อมูลแม่นยังสิ
ๆเจ้า
การเก็บกับข้อมูลเป็นเพื่อเอามาเป็นข้อมูลในการวิเคราะห์เขาในเรื่องงานการสังคม
เราเข้าใจโดยทุกเคยเอาไว้คุณก็เดี๋ยวคนอื่นฟังนะคะแต่ที่แบบผมที่อย่างโดยฟังเป็นเองเราโดยทุกคนชูมันแล้วเนาะว่าการเก็บข้อมูลนี่กันถูกต้องแล้วการเก็บกับข้อมูลเนาะมันอาจจะมีได้หลายรูปแบบอาจจะเป็นเก็บเป็นตัวเลขโบหรือว่าข้อมูลต่างๆเนาะแล้วการเก็บกับข้อมูลนี่เพื่ออย่างเพื่อว่าเขาจะเอาไปเข้าในการค้นคว้าหรือกับเพื่อจะได้พูดสมมติฐานเพื่อจะได้พูดว่าสิ่งที่เขาเห็นและสิ่งที่เราอยากพูดหันมันถือหรือโบเนาะเพื่อว่าจะไปดำเนินเข้าในการวิจัยในต่อไปโดยสว่าข้อมูลที่เขาต้องการที่จะไปเก็บมันจะมีอยู่2 แบบเนาะมันจะมี2 อย่างด้วยกันคือข้อมูลว่าข้อมูลลักที่ว่าบ่เคยเห็นการค้นคว้าหรือว่าเก็บกลับมาก่อนแล้วข้อมูลลักในนี้มันจะมีเป็นการสำรวจการสำรวจแล้วก็เป็นการสัมภาษณ์แล้วต่อมาก็จะเป็นการ Facebook discussion เนาะหรือว่าการสนทนากลุ่มหลายคนนี่เคยจะเห็นใน3 อย่างนี่ใครเคยเห็นอย่างมาก่อนในโบเห็นมาหมดแล้วเนาะโดยซึ่งว่า3 อันนี้มันมีความแตกต่างกันแล้วทุกอันนี้มันว่าการเก็บกับข้อมูลแบบที่โบเคยเก็บอยู่ใส่มาก่อนจะเทื่อเนาะเป็นข้อมูลใหม่เป็นข้อมูลใหม่ถึงต้องให้10 คะแนนต่อมาsecondary data หรือว่าข้อมูลมือ2เนาะเขาสามารถเอาได้อยู่ใส่ทางนั้นโดยข้อมูลมือ2ต้องคิดว่าเป็นข้อมูลแบบไหน
ข้อมูลมือ2เป็นข้อมูลที่มีฐานข้อมูลเราเก็บมาแล้วเนาะตัวอย่างก็คือของ LCS ของ Big Survey ที่เป็นเราสำรวจมาแล้ว
โดยขอเสียงปรบมือให้ทางเลยเก็บผ่านเก็บผ่านมาแล้วเนาะด้วยแล้วเขาสามารถซ่อมได้ด้วยไซส์เป็นข้อมูลที่เชื่อถือได้เนาะจะเป็นสถาบันโบหรือเป็นบทความที่ว่าคนที่ด่านแต่ตีพิมพ์มาก่อนนั่นคือข้อมูลมือ2เนาะแล้วต่อไปเป็นเครื่องมือทุกคนผู้บอกเครื่องมือในการเก็บกับข้อมูลนี้แบบไหนเนี่ยตอบได้ไหมคะแบบโดย
มีการใช้แบบไซเจียแล้วเขาก็ใช้แบบพวกเทคโนโลยีเข้ามาช่วยในการเก็บข้อมูล
เก็บได้เพราะเดี๋ยวที่ได้เพราะการเก็บกับข้อมูลมันจะมี2เครื่องมือเนาะโดยหลักๆแล้วเป็นของไซเจียแบบฟอร์มชาวเห็นได้ทั่วไปแล้วเครื่องมือที่แบบว่าเป็นอิเล็กทรอนิกส์นี้เนี่ยยังนอกจากจะมีมือถือแล้วยังมีโดยอิเล็กทรอนิกส์อีกบอแท็บเล็ตโดยทุกคนเก่งหลายเนาะนี่แหละคือว่าเป็นเครื่องมือในการเก็บข้อมูลเขาจะมีอยู่แบบนี้เนาะแล้วแบบนี้เวลาที่เขาไปปฏิบัติตัวจริงดิวิธีการเขาจะเห็นแนวไหนเนาะ
หนึ่งถ้าสมมติว่าเขาไปเฮ็ดกับเด็กน้อยเขาต้องเฮ็ดแบบไหนเวลาเขาเข้าไปอ๋อมีของขวัญนอกจากมีของขวัญมีอย่างอีกโบ
ทั้งเรื่องการเก็บข้อมูลกับเด็กน้อยมันต้องมีการขออนุญาตจากพ่อจากแม่ของมันเนาะ
ถูกต้องมีของขวัญการขอการปกครองจากนั้นมีอีกโบมีอย่างดื่มอีกโบเจ้าโดยเวลาอันนี้ขออธิบายเรื่องที่ว่าเคยเห็นได้ตัวจริงมาเนาะถ้าว่าเขาเป็นเหตุกับเด็กน้อยสิ่งที่เขาควรไปปฏิบัติเบื้องต้นปุ๊บนี่แม่นเขาก็ต้องเป็นการกลมกลืนกับบนที่เขาจะไปเก็บข้อมูลก่อนเนาะถ้าสมมติว่าเขาอยากได้ข้อมูลกับเด็กน้อยสิ่งที่เขาจะไปหาเด็กน้อยนี่เขาก็ต้องเฮ็ดให้กับเจ้าสบายใจก่อนว่าให้กับเจ้ามีการย่านเขาเนาะโบแมนคือสิ่งที่เวลาเขาเข้ามาเมื่อกี้นี่อาจารย์เข้ามาอาจารย์ให้อย่างก่อนคือละลายพฤติกรรมเป็นบอกทุกคนเขาเข้ามาเขาบริสุทธิ์กันแล้วเขาละลายพฤติกรรมกันก่อนโดยหลักๆแล้วการเก็บข้อมูลเนาะบ่ว่าสถานการณ์มันจะเป็นแบบไหนเขาต้องปรับตัวเข้ากับสถานการณ์แล้วคำศัพท์หรือว่าภาษาเขาก็ต้องให้มันแตกต่างจากที่มันเขียนลงมาเนาะให้เข้าใจง่ายตั้งการนำเสนอเบื้องต้นของการเก็บข้อมูลแต่จะประมาณนี้เนาะโดยถ้าหากว่าใครสนใจสามารถส่งข้อมูลมาสอบถามหรือว่าโทรสอบถามได้เนาะเนื่องจากเวลาเขามีจำกัดก็จะไปกับคอตบมือทำบ้านโอ้ยเอาไปหน่อยเด้อเก็บบ้านเก็บบ้านนี่เลย
ก็รู้แต่คงต้องฟังการสักตัวเป็นกำลังดี
ไม่โพสต์มากำลังสาวเป็นประเภทย่างไม่ต้องเป็นอะไรHow about your feedback? Yes.
Yes, I can feedback and forward. Có gì đâu cả. เป็นการสอนที่เพลินๆเนาะพวกเราสอนแง่ทุกตัวมือจะสับยูอันที่สองนะเป็นสับยูสิ่งงานระยะที่แบบอันใหญ่ขนาดเพิ่มเติมไม่ยังเบื้องเนื้อหาอยู่ด้วยกันเป็นสับยูแล้วก็พูดเราเป็นพูดต้องเอาตัวพูดเนาะระวังพูดกับอินสตรูเมนต์มันจะคนละอันน่ะ paper version กับ electronic version นี่อันนี้จะเป็นอาจจะเป็นเรื่องว่าสิ่งที่บรรจุหุ้นนะหุ้นมันมีอย่างไรดีstructure semi structure หรือว่า structure ก็แล้วแต่อันนี้เป็นว่าหุ้นมีอย่างไรเนาะสำหรับการเก็บข้อมูลส่วนว่าอันนี้มันตั้งใจเนื่องต้องสู้ในการเก็บข้อมูลซื่อๆเนาะก่อนเราก็แยกกันนี้เนาะที่อื่นกับพวกนี้นั่นแหละ
ไอ้พูดแล้วไม่แอกไงนะ
มาเดินกินขึ้นเดินระวังเดิน
เขียนน้อยไปยืนเตือนโดยเราแต่ว่าโดยทั่วไปก็ดีแล้วแหละเนาะแต่ว่าอยากให้อาจารย์ตอนสุดท้ายนะอยากให้สำคัญที่สุดว่านี่เขาเรียนนี้จะมีนี่ให้นักศึกษาเรียนเสร็จ
พูดแต่บุคคล
มีมองมีน้องเอง
เปลี่ยนจากที่ว่าขึ้นมาในสโหมดของแบบ
ซีเรียส
โอ้นักเรียนโรงเรียนขนาดไหนสักเยอะเช่นที่เขาอยู่ที่ชั้นยาอาจารย์ห้องเขาที่หน้าห้องที่เราให้ดูแล้วหน้าห้องหน้าห้องอัน
นี้สมมติฐานว่า
คนนึงให้ดูไปทางหน้าในบันเอาเองขอบใจเด้อที่ว่าอาจารย์ได้มีโอกาสได้มาทดสอบมีพวกมันทดสอบมาสอนมาฝึกในวันนี้เนาะอาจารย์เองเป็นสื่อวาสนาเนาะแต่ว่าคือโครงการอาจารย์สอนว่าอาจารย์ว่า
ว่าทำงานอีก
นี่ลักษณะงานครับ
มันคือวาสนาต้องงาม
ต้องเป็นคนมีลักษณะอะไรวันนี้เนี่ยอาจารย์จะเอาเกี่ยวกับเรื่องของการสั่งสมุดที่ฐานนอกวอยเขาไปได้เรียนมาตั้งหลายแล้วเกี่ยวกับเรื่องการสั่งสมุดที่ฐานแต่ว่าอาจารย์จะว่าไปได้หนีที่ประมาณ3 จุดที่จะเล่าเกี่ยวกับเรื่องการสั่งสมุดที่ฐานเนาะตัวที่1เขียนมาถึงเลยอาจารย์แต่ไม่อาจารย์ไปได้อาจารย์
อยากให้ตัวเอง
hypothesis
โอ้
เห็นที่บอนี่เดี๋ยวมันจะว่าสกุลสีดำเป็นสีอะไรจ๊ะว่า
ตัวสีดำเนาะ
แต่ว่าเวลาเวลา
วันนี้เนาะค่ะจะว่าเกี่ยวกับเรื่องการสั่งสมุดที่ฐาน แต่ว่าพอที่นี้ผู้ใดผู้หนึ่งก็ให้ได้บอกว่าเข้าใจเท่าไหร่เกี่ยวกับเรื่องการสั่งสมุดที่ฐานด้วยมันเน้นอีหยัง
มันเป็นการเดา
มันเน้นการเดา
โดยคาดเดา
การเดา
ไปลวงหน้าว่ามันจะเป็นจังซี่อย่างนั้น
เป็นที่เนาะ
โดยครับ
มันเน้นการเดาคาดหน้าไว้ว่ามันจะเป็นอย่างที่คนอื่นได้มีความคิดเห็นแตกต่างกันซึ่งโดยเฉพาะเป็นเรื่องการสั่งสมุดที่ฐานในเหตุการณ์ของการค้นคว้าเนาะตัวนี้นั่นอันนี้ก็เป็นอันหนึ่งว่าการสั่งสมุดที่ฐานเป็นเขาคาดเดาไว้ก่อนว่ามันจะเกิดเหตุการณ์ตัวนี้ขึ้นมาและก็เป็นกัน
คาดเดาจริงๆเนาะมันต้องเป็นการคาดเดาแบบมีเหตุมีผลว่าเขาเป็นสิ่งคาดเดาตัวอย่างเขาต้องได้ทบทวนเอกสารมาได้เอกสารตัวอย่างแม่อายุของแม่มีส่วนสำคัญที่ให้ผู้ผัดสารอาหารคือว่าสิ่งที่เขาตั้งสมมติฐานหรือว่าเขาคาดเดามันจะถูกแทนหมด
นี่คือ
ถือว่านั้นแกเท่านี้3 ทางที่ตอบมาโดยก็ถือว่ามันรวมในหันได้นอกการสั่งสมุดที่ฐานตัวประเทศในเมนว่าเขาสั่งสมุดที่ฐานโดยที่ว่าบริทีมใส่เรื่องรักการวิทยาศาสตร์เนาะเขาคาดเดาว่ามันจะเกิดอย่างขึ้นแต่ว่าทางนักเสียงสำคัญก็ได้บอกมาแล้วสามเมนเขาสั่งเกี่ยวกับเรื่องวิทยาศาสตร์เขาก็จะต้องมีเหตุและผลส่วนเมนว่าสรุปไปแล้วก็คือว่าการสั่งสมุดที่ฐานในเรื่องงานการคุ้มครองคือเราจะต้องมีอยู่2 ตัวพันแปรที่มันมีความพัวพันกันหมายความว่ามันจะมีของทาง exposure เขาเรียกอย่าง exposure ภาษาลาวตัวปัจจัยกับกับผลที่มันออกมาเนาะเรามีความสำคัญกันบ่มีการพัวพันกันบ่เพื่อเราต้องการจุดที่1คืออาจารย์อยากว่าการสั่งสมุดที่ฐานในการค้นคว้ากับการสั่งสมุดที่ฐานในการสถิติเนาะคือมันจะมีความแตกต่างกันคืออะไรยกตัวอย่างเนาะอาจารย์จะยกตัวอย่างว่าสมมุติเขาว่าเด็กน้อยที่พ่อแม่มีการศึกษาเด็กน้อยที่พ่อแม่มีการศึกษาจะมีคะแนนของการกินหลายตัวเด็กน้อยที่พ่อแม่มีการศึกษาอันนี้เนี่ยตัวที่1ที่อาจารย์สั่งแล้วที่อาจารย์ถามคือว่าตัวนี้เป็นตัวใดกับตัวที่2อาจารย์ว่าค่าเฉลี่ยหรือว่าคะแนนเฉลี่ยของการกินของเด็กน้อยที่พ่อแม่มีการศึกษาเท่ากันกับค่าเฉลี่ยของเด็กน้อยที่พ่อแม่บ่มีการศึกษาค่าเฉลี่ยคะแนนเนาะทั้ง2อันนี้ตัวที่1เป็นการสั่งสมุดที่ฐานประเภทใดตัวที่2เป็นการสั่งสมุดที่ฐานแบบใดตัวที่อาจารย์ว่าเด็กน้อยเนาะเนี่ยเขาได้ต้องสอนน้องมีตัวเรา
ในเมื่อเวลามันแล้วคือตัวนี้เหมาะในการศึกษาบ้างซึ่งว่าที่อาจารย์ต่างตัวได้ทำงานการต่างตัวได้ทำของเวียดนามการถึงพวกของเขาเนาะว่าเขาต้องการอยากพูดเกี่ยวกับว่าพ่อแม่มีการศึกษาเนี่ยเด็กน้อยเขาคาดคะเนเลยว่าพ่อแม่มีการศึกษาแต่เด็กน้อยที่เกิดในครอบครัวที่พ่อแม่มีการศึกษาแต่จะมีพฤติกรรมการกินหรือว่าคะแนนการกินอันได้สูงกว่าพ่อแม่การเด็กน้อยที่พ่อแม่บนการศึกษาและตัวที่สองเนี่ยอาจารย์ต้องการจะพิสูจน์สมมติฐานว่าอันคล้ายๆกับคำว่านู่นให้โพสต์สิทธิ์เลยว่าสมมติฐานที่เราตั้งขึ้นมาว่าคะแนนเฉลี่ยของกลุ่มที่หนึ่งกับกลุ่มที่สองมันพอกันแล้วเขาถึงเป็นพิสูจน์สมมติฐานเนาะแต่สิ่งสำคัญที่อาจารย์อยากเน้นอยู่ที่นี่ก็คือว่ามีจุดที่อยากเพิ่มก็คือว่าคำศัพท์ใดที่เราควรใช้และควรใช้เข้าในการสร้างสมมติฐานคือเราจะเห็นแล้วเนาะว่าคำศัพท์ที่เราควรใช้หรือสิ่งที่เราควรใช้มีอย่างนี้คือหนึ่งเขาต้องบอกว่ามันมีการพัวพันมันมีการสูงกว่าต่ำกว่าเนาะหรือว่ามันมีบทกระทบถ้าภาษาอังกฤษเขาอาจจะใช้เป็นคำ associated related หรือว่า higher หรือว่า lower แต่สิ่งที่เขาบอกควรใช้ก็คือว่าดีกว่าหลักกว่าเนาะถ้าภาษาอังกฤษก็คือว่า good เขาก็บอกให้ใช้ better เขาก็บอกให้ใช้ bad เขาก็บอกให้ใช้ benefit หรือว่าผลประโยชน์เขาก็บอกให้ใช้อันนี้เป็นสิ่งที่อยากให้นักเรียนเนาะอ่านจื่อไว้ว่าเขาควรใช้คำศัพท์ใดเวลาเขาที่จะสั่งสมมติอันเขาเรียนมาในเมื่อกี้นี่ทำไมนะเขามีอยู่3จุดอยากให้คำนึงถึงเนาะการสั่งสมมติฐานต้องมี2ตัวผันแปรตัวผันแปรเขาว่าตัวผันแปรอิสระกับตัวผันตัวเอาคำเนาะตัวที่เขาจะอยากได้ตัวที่2ก็คือว่าเขาสั่งสมมติฐานมันมีอยู่การสั่งสมมติฐานในเรียนอาจารย์ทุกตัวกับการสั่งสมมติฐานซัพพอร์ตเพื่อที่จะเอาไปทดสอบในเรียนสถิติในสถิติเนาะและตัวสุดท้ายเนี่ยยังให้ชื่อว่าเขาควรใช้คำศัพท์ใดและเขาควรหลีกเลี่ยงคำศัพท์ใดที่ควรใช้ในการสั่งสมมติฐานข้อนี้คือว่าอาจารย์บรรยายจบแล้วนี่อยากถามเพิ่มบ่
ก็ไก่ก็น่าสนใจ
พยายามถ้าเป็นเรื่องคนพอพยายามทำไมอ่ะ
ไอ้โซ่ที่ทานยังมันยาวๆนี่
ต้องเอาคำถามก็ได้เพราะว่าอาจารย์คิดว่าอาจารย์ที่จบแล้วเอาเป็นแบบว่าในนามเหตุเป็นใดเพื่อที่จะตื่นมาจะสูงที่สุด
ภาษาครูอาจจะมีสไลด์เบอร์
ไม่ใช่โมสนาโมที่สอนเป็นยังไงตอนแรก
โดยทั่วไปแล้วอาจารย์เข้าใจที่ดีเนาะอาจารย์แล้วก็เรียนให้แต่ว่าเวลาอาจารย์ยกขึ้นมาว่าส่วน exposure กับเอาภาพนั้นหลังจากคณาจารย์ได้เล่าแล้วอาจารย์ให้ตัวอย่างไม่ถึงเนาะว่าตัวอย่างว่าปัจจัยเห็นว่าเราเนี่ยคือแบบเอาคำนั้นเนี่ยต้องใจไว้ที่มันเรียบเราไม่บอกว่าเวลาเราไปทำการที่คนอย่างนั้นว่า exposure เป็นชาวทำเนี่ยเนาะงานจะบอก
I have a question. Just for you and for everyone, when you teach, is it usually with PowerPoint or was it just speaking or is it with the board that right? You use PowerPoint. Yeah. But you do any writing?
We sometimes that we want to explain about the toy in the PowerPoint, maybe you write on the board. But at the room of USAID, when I teach no board for me. Oh, I want to cover board. I'm sorry, then I support.
Yes, because sometimes I would like to hear your opinion, like, because sometimes I think when you write on the board, then the student has to write and it helps them think about it. Because when you just see PowerPoint, you can, I don't know, sometimes you don't pay attention. What's your experience of?
Yeah, I agree with you. Sometimes that when we explain for the PowerPoint, they might less attention to what you want to teach them or what you want to give them the point, the exam point. But sometimes that when you not give the PowerPoint in, they always give the comment or complain about that. Oh, we shouldn't have the PowerPoint before we enter to the class or something like that. Because we want to research, we want to understand, we want to navigate about the contents that you want to teach or something like that. So we try to make a balance for them. But as you know, for the students, they have many types of groups of the students and based on their opinion as well. Some students they might active, some students they might sometimes very
Oh, that's great.
How about your recommendation? We should have both PowerPoint and writing because I also want to improve my.
Yeah, I tend to always write on the board because I'm a visual explainer and learner, but I always have a PowerPoint too. So I usually have a board that I do problems on or write things on, but have a PowerPoint as well.
Yeah, I think now students, they expect PowerPoint, otherwise they're just complaining. So you have to balance, but I think that there's a real value for writing. Because then they have to like just think and understand and then write also. And then they have those notes and it just helps reinforce the idea. And what I like to you are writing the whole sentence, you know, so even if I don't understand now, if I write it and look later, I can helps to understand later, you know. Like even though you're writing a lot, but I think it's useful because you can go back later and study again and understand better.
For the student who maybe the student it doesn't quite understand what they wrote down, what the teacher wrote, they can read again later and ask their friend. And
Yeah, have time to think.
yeah. In my experience for training and teaching, the challenge with PowerPoint is that sometimes they're reading the PowerPoint and not listening to the teacher. So that's why sometimes you have to be careful about so sometimes I explain, then I put the PowerPoint. Because I don't want them to read while I'm talking. I want them to look at me when I talk. And maybe I write on the board and then I show the slide summary or I show after. So I need to look like this.
So I'm just talking and I'm like, oh, look, that's the next 4 slides. But yes.
Yeah, great.
Yes.
Like you cannot come and get still have the meeting.
Okay, maybe if you do
Yeah, sure. So.
break on time.
Yeah. Cho nên học vào sau khi chưa bây giờ và vì là nên bị son thì không bị cái nào bị phải cái nào làm sao.
Everybody is refreshed. So I managed to do something to my computer, so I need to like get help from Lee, so I will do my best on this. So I can advance with this, right? Yeah. Did it stop?
I will share here. Yeah. Is it okay if I just try to like? You want to use it? Is it okay? Yeah, if it's gonna take over your whole computer. No, I need this one. Okay, yeah. Is it? I'm so sorry. Or I can go to that one. If you set that one up, I can do that over there too. Okay, so I'll try my best to do this way. Let's see where we left off. Okay, how is it? Ready? Yes. So we're going to talk about logistic regression, and I'm going to try and just do several examples with all of you to talk about the interpretation. So how many have seen or you've done with logistic regression before?
Long ago.
Long ago? Anybody? Have you seen papers with logistic regression? Or odds ratio, that kind of thing? Yes.
Yes, we did.
Okay. Okay, so we'll talk a lot about interpretation, but here is the idea that we talked about, right? So let me go quickly back to our old actually, you know what? Let's see. Sorry guys. Yeah. Okay, that's what I want. Okay, so the idea here, just to refresh, we have some probability that we are interested in. For example, it's the probability of anemia. We're interested in whatever this is. We want to reduce the amount of anemia that we see in a population. So this is why we're studying something like this, right? And so what we do is we look at the odds of anemia, right? And then we say that we're going to make a model that is log of the odds, and we're going to say that it is just like any regression. And the X is something that we think is modifiable, right? Like maybe it's knowledge about good eating practices, maybe it's actual good eating practices, maybe it's something economic or social determinants, you know, whatever it might be. Maybe it's an intervention. So those are things we can change. The log odds, which means that we would change the odds, which means we would change the probability or the chance of having some bad outcome. So that's what we're trying to do. And then we can, you know, so that is the model. Let's not worry about this, but this is a funny, you know, it's a funny kind of complicated equation. If we just try to do algebra and find P equals what, this is how it would look. So if you try to graph what that looks like, it looks like this. So here I took this from somewhere and it uses pi, but this one is probability and this is X. So if this beta, that is the slope here, if that beta is positive, the graph looks like this. So as X is getting bigger, the probability is increasing. But it's not a straight line, it's kind of like a curve like that. So if the slope is positive, the probability increases like this. If the slope is negative, the probability decreases, but it decreases on a curve. That's the idea. And then if beta is equal to 0, then it's flat. So that's the idea. It's kind of similar, but it's just not a straight line. It's a bit of a curve. So what that means is, it's not, okay, so it's not linear, and a change in X. So if you go X by one more unit, like maybe this X is years of maternal education, if you go up by 1 year, then the effect depends, right? If this is the case, suppose we're looking at something positive, like a good health outcome, and the chance of a good health outcome is increasing with maternal education. Then if you go up from this amount to this amount, like go one step, 1 more year of education, if it's from here to here, the increase in the good outcome is pretty good, right? But if you are here, if you go from very high education to another high education, the increase is a bit small, right? Also here, if you have a very low education and you increase by 1 unit, the increase is also quite small. So the amount of increase in the probability really depends on the value of X. It's not always the same improvement. So a change in X has less impact when the probability already is very low or very high. Does that make sense? You were not listening. I saw that.
Oh, yeah.
You had your phone.
I was waiting for someone to respond to.
Is anyone who's listening, or what do you think?
Yeah, actually, I was listening, but just maybe.
Sorry, I'm giving a hard time.
Maybe couldn't you give us a reason why we have to make it only between 0 and 1?
Because it's a probability. This is trying to graph probability. Probability by definition has to be between 0 and 1. At some point, if you go more and more maternal education, then the chance of that good outcome is getting more and more likely until you're close to 1, which is like certainly. But you never quite touch 1, right? If you touch 1, that means for sure, no exceptions, something is going to happen, which in real life, it's never like that, right? And if you touch 0, it means that it is impossible, that it will just no chance whatsoever, which again, in a health scenario, is never going to happen. You can't guarantee that you will be completely healthy or completely free of disease, you know, like, so that's the idea. So the improvement of X really depends on what X is. In the middle, you can see a good improvement. At very high values or low values, you may not see good improvement. Now, so you see if beta is positive, the probability goes up as X gets bigger. And if beta is negative, the probability is going to go down. And of course, 0 means flat. Now, if beta is positive and it becomes more positive, this curve will become more sharp. It'll go more quickly up. This smooth area in the middle, it'll become, here, I'll draw a picture. So right now, beta is kind of like this. If the beta and beta here is positive, the slope is positive. If you make maybe this one is 2. Suppose you make it 4, it will become more sharp like that. It'll have a place where it's flat. So that's what beta does. It makes this S curve like really steep, like a mountain, as opposed to something smooth. Is that clear? And the same thing, when beta is negative, the probability is going down. And if it becomes more and more negative, this drop will become very sharp. And actually, like the place at where this intercept, the meaning of this intercept, is just where this transition is occurring. So as this intercept changes, this will move a little bit to this side and that side. So that's the meaning of these coefficients. Is that okay so far? So we're going to let's play around for it. When you do this, you don't really have to get into all of these. This is just to understand, we're going to want to make an estimate of this number. Like what is the slope, as always. That will always have some kind of p-value, it will have a confidence interval. And when you're looking at output, whether it's Stata or SPSS or R or whatever software you're using, there are different kinds of statistical tests. So I just wanted to write the words. One common word is wall. Sometimes you see that. Sometimes you see this thing likelihood ratio test or LRT. Sometimes you see the word score, statistic. So there are a few different methods to test the significance and to make a confidence interval. And usually, like, it's not a big difference. Some of them might be better for a larger sample size, some for smaller sample size. But you will see all of these. And usually should be, relatively similar, unless you have a very small sample size, then you might see some differences. So just look for those kinds of words when you're looking at output. So we had this, I'm actually going to go into this in a lot more detail. I made it bigger on the other PowerPoint. But before I go to that example, let me just talk a little bit about
about binary indicators, right? Like this whole example I've been using is anemia. So we have hemoglobin and then we have some cutoff and you just say, are you not anemic or you're anemic, right? So you take something that is a number, it's a continuous measure. And then the point is that we are not interested in that whole value of hemoglobin. We're only interested in kind of the bottom side, right? I don't care if your hemoglobin is 13 or if it's 14. I mean, I don't care very much because it's both healthy, right? But if your hemoglobin is 8 or something like that, then I'm worried and I want to know. I'm paying attention to the bottom of the distribution. So I just want to just make this point because we make these decisions all the time. You might ask, for example, if you're studying anemia, should I study the hemoglobin or should I study anemia as an outcome? Do I want to just make a categorical or do I want continuous? And there's some thinking here. So if this is hemoglobin, then in the population, you might have a distribution like this, right? And maybe here is the cutoff for anemia, right? So any low number, this is anemia. And for us, that has some clinical meaning, and that's why we care, right? So when we look at anemia, all we want to know, are you on this side of the line or are you on that side of the line? And we care because it has a clinical meaning. Those are the things we want to improve. We can look at it on the top of the distribution too. So if this is cholesterol, then we're interested if yours is too high, right? So are you too high in your cholesterol or are you normal? You may not be interested in the low side that much. Anytime you do this, anytime you take a number and you make it categories, you lose information and you therefore lose statistical power. So it has a clinical meaning and that's nice, because that's what you're interested in, but you're throwing away so much information, right? And so that's a consideration. I generally say, if you have a choice, stay with the continuous because that has more information. You're not throwing it away. Use the full information that you have. You might miss something very important, right? Even if somebody is here and their hemoglobin is very low, and maybe after intervention, they move here. If you just do a binary indicator, you go from anemic to anemic. You say there's no improvement, right? But in truth, there was actually an improvement. Okay, that person is still anemic, but maybe they went from severely anemic to just anemic. And I would say that is important. But if you have an intervention that moves someone from, 7 grams per deciliter to 10, I would say that is really important, right? Even though it's not solving the whole problem, but it's still worthwhile, right? So you miss that information if you just make it 2 categories. So there might be important intervention effects, but then there's some subtleties. So for example, when you treat this as continuous, what you're trying to do, say you have an intervention, what you are looking for usually when you treat it as continuous is that there's a mean here. And what you ask is this mean moving? In truth, the intervention may not affect the whole distribution equally, right? Maybe your intervention is very effective for people who are already healthy. Maybe these guys will move and the ones who are very disadvantaged don't improve as much. Or maybe you have good targeting and these guys improve a lot, and these guys don't change very much. So sometimes you have interventions like that, where the effect of an intervention does not affect the whole distribution equally, and that could be for biological reasons, it could be for social reasons, it could be your implementation. For example, if this is some kind of, more social behavior change, maybe there's some bias or something where people who have very low values are not receiving the intervention very well, right? Maybe you have a health campaign where you're looking at, Like, so, like, a lot of times, like, people who are kind of the bottom of the distribution, they're disadvantaged, they live in poverty, they might have lower education, for example. Maybe you are doing an intervention where you require people to come to the clinic to receive some information. But in order to come to a clinic, you need to be able to pay for a bus or some kind of transportation to get there, right? So then these people might not get affected by your intervention. These people might get your intervention, these guys might move forward, and these guys might stay the same, right? So you have to just kind of think about, you know, what's happening. When you do statistics, you're assuming everyone is moving by the same amount. That's the sort of assumption in your model. So just kind of keep that in mind. Okay. Let's see. Okay, any question about that? Does it make sense? All right, so let's actually do some examples together. Okay, I just made this big because I was always trying to make it big. I just put it on the slide and it's bigger. So this is that table 4, and I'm just looking at that bottom part where, if you remember in this table, we're looking at maternal hemoglobin and anemia before pregnancy, and looking at child outcomes at 3 months. So this is the Y variable. Child anemia is our Y, and it's binary in this situation. It's anemic or not anemic. So we want to do logistic regression. And they do 2 different kinds. One is where the X is continuous, and this is where the X is categorical. And then they have some estimates that they make. And then they also do an adjusted analysis, which is the same analysis, but now they control for some other factors. So they add more factors to the model. So for the same question, we are going to have 4 different estimates. We have this one, this one, this one, and this one. And so I want to kind of talk about and understand what the differences are. So let's start with this first one here. These are the numbers that are here. If you see the footnote number 2, the values are odds ratios with 95% confidence intervals. So, and then we have maternal hemoglobin, anemia in the child 0.92. So let's just ask, what are these? So what are they doing? Like, can you let's just walk through what it means? Can you tell me, like, what is the research question again for this? You might say, is X associated with Y?
Hemoglobin and anemia and delivery.
Is hemoglobin what?
Hemoglobin level associated with the
Whose hemoglobin?
a mother.
Of mother before pregnancy.
Yeah.
Associated with hemoglobin. Child, right?
At delivery.
This is 3 months. Okay.
3 months, 6 months under.
Okay, so what are we doing? We are looking at this probability. This P is the probability of child anemia at 3 months. Right? That's the outcome that we want. Or what we want to know. Does this child have anemia at 3 months? The probability that, that is, we're going to call it P. So our model is going to be log P 1 minus P is equal to 0, 1, X. And X, that's the hemoglobin of mom. Of mother. That's our model. Okay? And what we found is an odds ratio. So what is the interpretation of that? So the beta that would be estimated is if X goes up by 1, then the log of the odds will change somehow, right? So if the hemoglobin of the mother goes up by 1 gram per deciliter, then the log of the odds will change so much. If we take e to this power, then we get the odds ratio. So the number here, oops. What this number means is if my hemoglobin goes up by 1, if the mother's hemoglobin goes up by 1, the odds of the baby having anemia gets multiplied by 0.92. It goes down by 8%. That's the idea. So if maternal hemoglobin before conception is greater by 1 gram per deciliter, if what we calculated, OR odds ratio is equal to 0.92, right? That's what we calculated, or what they calculated in the paper. If maternal hemoglobin, the X, goes up by 1 unit, it means that the child's odds of anemia at 3 months is going to be multiplied by 0.92. That means it's a reduction of 8%. If you multiply by 0.92, you bring the odds down, which makes sense, right? You're saying if the mother has better hemoglobin, then the child is less likely to have anemia. You expect the child to have better hemoglobin, so they won't have it, less likely to have anemia. But specifically, it's not about probability, it's the child's odds of anemia then gets multiplied by a number less than 1, so that you see some improvement. Now, you always have to ask, is this significant or what? And the answer to this is a little bit tricky. They don't give us p-value in the paper. What they give us is 95% confidence interval. And we always said, okay, well, for odds and relative risk, we look and see if this interval contains 1. And normally it's very neat, but this one, it's on the edge. So what will happen in this particular case is actually that the p-value is basically 0.05. So then you can say, is it significant? Is it not significant? And you can argue the point, right? Instead of making an argument, they just said, look, it's like this. It's borderline kind of effect.
Should not be.
What's that?
So it should not be significant.
Yes, if you want to be very stringent, but the whole point of a p-value is that people can decide, right? Like you might say, I need p to be exactly less than 0.05. Otherwise, I'm afraid of type 1 error. I want to be strict. Somebody else would say like, no, I want to like be a little bit looser. If there's something there, I want to be able to discover it. I use p of 0.10, right? So people differ. Most people use 0.05, but this is an arbitrary number, right? People just picked a number and everybody uses it. But so it's helpful sometimes to have the p-value, but you have the confidence interval. You can see there might be some reduction in the odds, but it's kind of borderline. It's not that big, right? The effect is not that big, but we can keep interpreting that. Okay, let me keep going. Okay. What if, in the same scenario, maternal hemoglobin goes down by 2 units? This is rather tricky. Because this is not what we're used to for regression. You have some kind of odds, let's just say odds of anemia. And you said if it goes down by 1 unit, then you multiply by this odds ratio, right? But then it goes by another unit, so you multiply by this odds ratio again. So it's a multiplicative effect, it's not addition, which is a very strange thing. So it's sort of like this. It gets multiplied twice by 0.92, so sort of like 0.92 squared, which is 0.85. The odds gets reduced by 15%.
And multiply power.
So you can see if you go by 2 units, it's to the power 2 of the odds ratio. If it's 3 units, it would be to the power of 3. So it's not a straight line anymore, right? When we saw that graph, it's a curve. So that's the interpretation. And if you go by 5 units, you know, this number gets smaller and smaller, but not in a linear way. The odds will progressively get smaller. We'll do another example, but this is a new idea. So now, so this was when we treated the X as continuous, right? Now let's go back. There was another version. The second one here, where we made the X categorical, right? So what they're doing here is they're saying now we have log odds of anemia of the child anemia is equal to beta 0 plus beta 1 X, but now this X is going to be some kind of indicator where it's how we did it kind of before this yes, no, 1, 0 idea. 1, if this X is equal to 1 if mom has anemia. And it's equal to 0, mom not anemia. So this is using that trick where we say, okay, anemia, not anemia of the mother is categorical. It's not a number. We shouldn't be able to do regression, but since we use this kind of coding, if you go up 1 unit, you would go from not anemic to anemic. So if the mother becomes anemic, then the odds is going to be changed by 1.37. So let me write that down. If a mother is anemic, it went from non-anemic to anemic, then the child's odds of anemia at 3 months is multiplied by 1.37. So this is different. Hemoglobin, if you go up, things are getting better for the mother, right? If anemia, if it goes up, you're getting worse. The mother is getting worse, you expect the child to get worse, right? And in fact, they do. They get, their odds now are increasing. The odds of anemia increase by 37%. That's the interpretation of that number. And that one was actually significant. If you go back to the back to this, it was 1.37, and then you can see this interval does not include 1. So actually that is a significant difference. So the odds of anemia for a child will increase if the mother also was anemic before conception. Okay. And then you might say, okay, are we okay so far?
We could also using the formula again and get some numbers in there and try to calculate the I'm not so sure that everyone understands that.
Oh, we will do an example with the number. Actually, I think it's the next one. Let me just talk about this adjusted and unadjusted. You have a model like this, right? This was anemia. You can always add things to the model. maybe there's a beta 2, X2, and this one is sex of the child. Or you can add beta 3, X3, and this is age of the child. Okay, here it's all 3 months, but you know, you can add socioeconomic status, you can add other kinds of variables. And the things you add here are typically things you think that are all going to affect child anemia. So, you know, what could have happened? I think we discussed it last time. What are the things that could, other things that can affect child anemia? It can be, you know, maternal diet, it could be delayed cord clamping, like there are many kinds of other things, environmental effects, ill morbidity in the child. And actually what they did was this, they had, they adjusted for maternal age, minority status, education, I think this was in Vietnam, right? Education of the mother, socioeconomic status, sex of the child, age of the child, they had some intervention here. How much time before conception, early initiation of breastfeeding, and morbidity in the child in the last 2 weeks and in 3 months. So these are extra variables that they think are going to affect the outcome, and then they adjust for them. And what happens, and this will always happen, these numbers will change, right? So you had an estimate here that was 0.92, it became 0.93. Here it was 1.37, it became 130. Sometimes these numbers, when you adjust for things, they change a little bit. Actually, you can see that this goes from significant to not really significant anymore. When you adjust for these other,
Me too.
yeah, even serious loss. Yeah, so these things will change slightly. Sometimes they change a lot. And sometimes it's because these other factors are really explaining a lot of the variation, and they kind of explain away these differences. And it really depends on, and Dr. Kate probably could spend like 2 days talking about like how these different other factors could be affecting the outcome, could be affecting the exposure, which is maternal hemoglobin or anemia, and then therefore change these kinds of estimates. So you want to kind of pay attention to these. It is always good, if you're doing an analysis like this, you have your hypothesis, you know the X and the Y that you want to have. You make a decision whether it should be continuous or categorical. You then plan the right kind of analysis. Is it going to be logistic regression or normal regression? And then you also should make a plan of what these things ought to be. You don't want to just try things and say, maybe I'll control for sex, maybe I'll do age, maybe I'll drop age and I'll do education. And so, you know, like you don't want to kind of make these things up as you go along. There's usually some reasons for having these, and you decide them ideally before you look at all the data. You just decide what is the proper thing. And, you know, child anemia, I know it's related to socioeconomic status. It's a very consistent relationship. I want to control for socioeconomic status in my model. So you determine these in advance. You're not always just like looking, because what happens is this sort of thing happens. Here you have a significance result. You're like, hooray, I can write a paper, make a poster, and then the effect is disappearing.
Yeah.
Or it's losing its significance. So then you're like, what if I quietly drop this variable? You know, it gives you a chance to cheat, and you don't want to, you don't want that temptation. So it's better to have your analysis plan beforehand and then stick with it. You know, it's a little bit disappointing, but for me, I would, and they do this in the paper too, right? Like they present this and they say like, okay, you make your judgment, like how you interpret this change. For me, I would say like, that it seems like I would say there's something happening here, but probably it's not a very strong effect, right? But it's still having a role. If you look at, and they do this analysis at 6 months and 12 months and 24 months, and there seems to be like some effect that is small, but like kind of persisting, which suggests that, okay, it's not a major effect, but maternal nutritional status before conception does seem to have an effect on, you know, the 1,000-day well-being of the baby. That's the kind of general conclusion that they made on this paper. And then you can debate, like say like, I don't agree, or it's not strong enough evidence.
you can have that discussion, which is what people do.
In this case, you think there might be some covariate that we should not really
What's that?
in this case, because they adjusted with some factors or whatever variables in there. And if I would like to make it significant for the adjusted column, which actually not okay, but how do we decide which ones should go out? Yeah.
How do we decide what is here?
Yeah, the first one, like this case.
Yeah.
This case.
Oh, you adjust for what exactly? How do you decide? Is
Yeah.
that the question?
Yes.
So, like, presumably, if you do the study, you know a little bit about anemia, right? Not just the biology of anemia, but also anemia in a public health kind of setting. You know the things that are affecting, whether they are biological, like, for example, child feeding and morbidity, right? That's a little bit more biological, but then things like socioeconomic status, maternal education, those things are more social. So both from kind of a medical background, but also from a public health background, you have literature, you have seen other studies, you understand the biology, you understand kind of, what is happening in a household in a certain culture, what kind of feeding is happening. So you have specific hypotheses. You wouldn't just put something because it's interesting. You will have some hypothesis about it. But this is not your primary research question. It's just that you know that every single outcome we look at always has many factors, right? And that creates noise. And every time you have like extra variability, it reduces your statistical power, right? So adjusting sometimes helps you find the actual message in all that noise. So yeah, you will have a sense, because you understand the system.
Yeah, because sometimes I try to separate the independent variables in some group. For example, socioeconomic, we look at socioeconomic first, and if medical history, we look at medical history, and something like that, and then we consider that first before we put it into the one model.
Yeah, so I have an example that kind of looks at that, where you have many different things. I think we sent another paper today before my computer got stuck. So that does exactly that. So I know you didn't get a chance, but we'll talk about that paper. Okay, so we did this. This is an interpretation. Let's do another example. So this is getting into looking at numbers. So this is just kind of an exercise. So here's a story. Let's say that you are just doing a study of, infant and young child feeding this is in Nepal, and you are looking at breastfeeding practice, and you're seeing, is the child still breastfed? So you have children from the age of what are they, right? 0 to 35 months, 236 children, and you have the child's age in months, and are they breastfeeding? Yes or no? So you want to look at the relationship between age and breastfeeding. So you're going to do a logistic model because the why that you're interested in is breastfeeding, right? And this is yes or no, right? Is the example, it's clear, the example? Okay, so it's a very straightforward. You're not looking at many variables. Is this child breastfeeding, yes or no? So, and then you have age, right? So your X is age of the child in months. So how is, what's the model again? Can you tell me?
Log
E divided by 1
minus P
equal
intercept plus slope X.
Yes. Okay. So X is age, what is P in this scenario?
probability of breastfeeding
Equals of child breastfed, yeah. Okay, so say I go on Stata, so I don't have Stata here, but like say I go on Stata, this is my model, I fit this model, and that's my result. So the intercept, it's something like 7, oops. Okay, and then this is the slope.
It moves when X moves.
Why move?
Okay. So now this thing, like remember we're modeling odds and log of odds, right? But in truth, we're interested in the probability. So say that we want to just talk about probability. Just the probability of breast, if this is the model and you get these estimates, right? 7.4 and negative 0.25. Does the probability of breastfeeding increase or decrease with age? Does the odds of breastfeeding increase or decrease? How about that first? Why decrease?
Because it's low. Minus. I have no idea.
Does anyone have an idea? It decreased. Yes. So this is your slope. This is your slope. This is your intercept. The slope is negative, right? I'm about to change it. Is that okay? Remember this one? Remember this? The slope? If the slope is positive, the probability is increasing. If the slope is negative, the probability is going down, right? And the odds will match this. The odds will go up or the odds will go down.
Go down.
Right? So the odds is going down and the probability actually, you guys know this. As the older you get, you stop breastfeeding, right? The baby is getting older, you stop breastfeeding. Probability should go down, the odds should go down. Because this child is getting older, you don't need to breastfeed anymore, right? Like, so you do know this, but also, your data are supporting this, right? Your data is legitimately supporting this because this number is negative and that's the slope. The odds should be going, the log of odds is going down. The odds is going down, the probability is going down.
Just a joke. It's why because I haven't read that before. So I didn't.
You don't have the lived experience.
Yeah, okay.
Okay. Okay. So now we know. Okay, now let's actually use some numbers. Okay. So we generally like to record odds ratio. What is the estimated odds ratio for being breastfed if you have a 10-month-old child compared to a 9-month-old child? So anytime we talk about odds ratio, if you remember Kate said ratio, compare something to something divided by something, right? So you can never say, what is my odds ratio when a child is 10 months? It has to be compared to something else. Otherwise, it's not a ratio anymore. So you always are looking for compare what to what. You have a 10-month-old child has an odds of breastfeeding. A 9-month-old child has an odds of breastfeeding. What is the odds ratio? Are you raising it? No? Okay. So how do we know? Okay, we have. Actually, I don't need to write that again. Yeah, no, that's one minus b, and this is, remember, that's odds, okay? It's equal to, actually, you can write it. 7.5 minus 0.25x. So odds of breastfeeding. This is age of child age. Right? So when X, so if you go from 9 months to 10 months, the increase is 1 month. Right? What you're really asking, what I'm trying to ask you is, if I increase the age by 1 month, how much is the odds changing? Increase. Yeah, right. Very good. So if X increases by 1 month, then log of odds decrease by 0.25, right? It goes negative by 0.25, which means the odds. How do you get from log odds to odds? You go e to that negative.
Negative 0.25.
Which is, I think, some number, and I wrote it down.
No matter the.
It's 0.7.
No matter the intercept.
Yeah, it doesn't, yeah, the interceptor, actually the intercept is, yeah, we don't pay that much attention. The intercept will tell you exactly when does that dropping off of breastfeeding happen, at what age, what value of X, which, is interesting, you want to know that, but not right now, right? Not in this application, you're not thinking about it. So I think I calculated this, and you can try calculating with this. I have this, so when you get the slides, and you can send the slides since you have them now, 0779. What I did was in the slides, when you get them, if you look in the comments, the notes section on the bottom of the slide, there's a notes section. I did this whole, I put the answers. So so if you're just practicing by yourself, you can see the answers, and see the formula of how I did. So if the child is 1 month older, the odds will be multiplied by 0.779, which means that it will go down about what, 28%?
Yeah.
20. No.
No, 22.
22%. 22%. If I increase, and notice that it's a bit of a trick. I said from 9 months to 10 months, you have this, your odds will be multiplied by this amount. If I had said 24 months to 25 months, it would be the same calculation, because the point is that it changed by 1 month. Now, next level. What is the odds ratio of being breastfed for children who are 24 months compared to children who are 18 months?
18 months. And 24 months.
18 to 24.
6 months interval.
So if X increases by 6 months, then log odds decreases by
6 power.
First, let's do log odds, right? decreases by, well, 0.25, right? At 1.5. Right, so odds will be, and so decrease, right? So this would be a negative. It's negative. Its log odds is this much, so we take it to e to the power of negative 2.5 times 6 is e the negative 1.5, which is some number I calculated in the comments. 0.223. So that is our odds ratio, 0.22.
Decreased by 77%.
Yes. So your odds, whatever your odds are, when the child is 18 months, if you go 6 months later, the odds gets multiplied by 0.223, which is a lot. It's a big reduction, right? Which is not surprising. 6 months is a long time for a baby. It's very possible that you might stop breastfeeding within 6 months, in a 6-month period, right? So it's not surprising that the odds will go down by a lot. But again, it's multiplying, as it's the odds ratio, it is multiplying by 0.22, which is like decreasing by 70%.
I forgot the value of E.
E, it's like 2.7 something, but if you look in your calculator, you will find like e to x, and that's the power you can use. Or in a Excel, you can just say equals exp, put the number in the parentheses, and it'll get you that number.
Exponentially.
Exponential. Yeah, if you look at the calculator app on your phone, you'll see it there. So you never have to type out and calculate that. Okay, so again, when you so you can see all of this stuff, it's in the comments. So when you get this slide, when you get this stuff and you just want to practice some more, I just have the calculation there and I have the answer. So you can just check yourself and make sure you're comfortable. Any questions? I think this is very new, a little bit new. Yeah. That's okay. Okay, let's keep going. Okay, so let's see, how are we doing? Okay, we're doing okay, actually. We might even finish early, because I'm surprised. I thought this would take a really long time, but okay. So I sent, or rather we should have sent you this paper. This was a study in Bhutan, and it was looking at malnutrition. And it was a very kind of straightforward type study. It's not experimental, it's purely observational. And it was looking at risk factors for malnutrition among young children in Bhutan, and looking at, different risk factors in nutritional status, looking at under 5 children. And I wanted to go through the results, but I thought it would also be nice just to read the methods together, just to see if you can follow what they're doing. So here is this, I just copied and pasted from the paper. You can read the whole paper and, read everything. But this is purely the part of the methods that said statistical analysis. So this is what it is. So first sentence, they use Stata for statistical analysis. And this is very common when you're writing a paper. If you use some software, you say what version it is, and then something about the company and where it's from. That's a very common, this first sentence is a very common sentence. You might say SPSS or Excel or whatever you like. So then they estimated the prevalence of undernutrition. They looked at C-scores, especially height for age, C-score, and they presented the results. So this was using one of those national surveys. So they presented the results by region, urban, rural. They looked at household socioeconomic status, maternal education, child age, and sex. And then the data analysis had 2 phases. So they did first this univariate linear or logistic regression. They looked at height for age, and then they used the cutoff, and they said, okay, if you have low height for age, you have stunting. So they did both. So when you look at the paper, you'll see one table that is HAZ, and another table that's the same regression but for stunting. So one is the normal error regression model, and the next one will be the logistic regression, because it's a binary outcome. So in each one, they use either linear or logistic, depending on the outcome, and they identified variables associated with either the Z-score for the regression or the stunting for the logistic regression, and they looked at stunting as -1 or -2, and or -3, and then they did wasting as well. So -2, they did overweight, underweight. And so notice how they're defining every single outcome that they were interested in, and they tried different cutoffs. So everything is well defined, right? Okay, so -2, weight for age. Now here's what they did. So you have an outcome. So say you have stunting, and then you have many possible predictors, like sociodemographics of the child, of the household, and so on. And you are interested in every one of those predictor variables. So what they did here, and this, I think some of you have been asking this question, so I thought this would be nice to show you. They looked at each predictor, every X, one by one. And that's what they mean by univariate analysis. I have X1, X2, X3, everything is interesting to me. But I take the first one and stunting, and I look at the relationship, is it significant or not? What is the p-value? Then I start a new model, X2 and stunting. Check it, what is the p-value? Okay, put it in my table. Then take X3 and stunting, get the p-value, and do all of them. And what they did here, and this is a very common thing to do, is for each pairwise, one predictor with stunting, they looked at the p-value and they identified all of them with the p less than 0.1. And they said, those ones I'm going to put in a multivariable model. The 0.1 is a choice. Some people use 0.2. Some people don't even like this method, but this is a very common way to do it. So let me use the, I can, let's see, this pointer. Does that work? Oh yeah, okay. So it's easier than me stretching my arm here. Okay, so variables associated with each outcome with a p of 0.1 were included in the multivariable regression models. Then they said, we also adjusted for child age, sex, household wealth, and type of sanitation facility as contextual covariates in the multivariable model for stunting, even when they're not significant in the univariate analysis. So they're kind of doing half and half. What they said was, okay, I have X1 through X10 or X20. I have many X's. I do one by one. I check the p-value, and if the p-value is less than 0.1, I add it to the big model with everything. But then they said there's some things that even if the p is not significant, they want it in the multivariable model, because they just said, like, look, you have to put child age, you have to put child sex. Even if it's not significant, it feels like this is important. You're talking about stunting, and we know stunting is progressive. Older children are more likely to be stunted than younger ones. So that's what that sentence is saying. You add them to the multivariable models for stunting, although they were not significant in the univariate analysis. And they actually have a citation, because someone might say what I just said, like you're mixing, right? So what's the justification for this? Well, okay, look at these guys. They also did the same thing. And they're published, so you should publish me too. So that can be kind of thing. And, some people will disagree, some people will agree. It's fine. I think it's fine. I think it's reasonable, personally, but you might disagree.
I do not.
I think Dr.
Might be good. Might be explain a little bit the reason why I accept the reason why because the data that you got, you have respected your data, not just giving the reasons like that.
Oh, what is the justification of adding some
Yeah.
things even if
Yeah,
they're not
even if it's not
significant?
significant, but
So-
to add it.
So for me, I have done this kind of thing where I pick a p-value, and if it's below in the univariate, I add it to multiply. So I've done it before, and so obviously I must be okay because I did it. But I always am kind of unsure because there are times where in the univariate it's not significant, but it can be in a multivariate situation, or sometimes there's a effect modification, like there's some complicated things that happen, where the univariate is not giving you the right indication. So generally speaking, because I have done things in different ways, my preference is usually if I have an X, every X variable has a reason. Like for me, like if I say I'm going to make a model and I want to collect data on child age and socioeconomic status and maternal education, it's because I really have a hypothesis that I think maternal education will affect them. And that's based on, literature, the experience, the papers that I read in other countries. This one is Bhutan. Like, I don't know if maternal education is important in Bhutan, but I know it's important in many other countries. It's reasonable for me to hypothesize that it's important in Bhutan. So for me, I generally say, like, I'm going to include the X's where I have specific questions, and then I will put them all in the multivariable model because I'm driven by hypothesis. If you use a p-value, you're kind of saying like, okay, I'm going to let the data do the talking. And that's the basis of my decision. And that's also valid. You can decide whether you're going to build a model based on what the data are saying, or whether you base it on kind of your theory that you come to look at your data. And different people do it different ways. But you just have to be able to justify, and that's what they're doing, they're justifying, and then you see the result. So you can know, I mean, they might say I'm adding it to the model, the multivariable model, and then it's not significant, then okay. I can demonstrate the p-value is not significant. I added it, but then I learned it didn't matter. And then there's this whole other thing. So there's this thing, a variance inflation factor was checked for each univariate predictor to assess whether the predictors were highly correlated. And all tested variables reported variance inflation factors less than 3. This is about an issue called multicollinearity, which Roger talked about last week. Anyone remember what is multicollinearity? He mentioned that variance inflation factor when he was talking. It's in the slides, so you have it. Do you know what's multicollinearity? When you have many X's, it's very reasonable that somehow some are associated, right? For example, maternal education and paternal education. A husband and wife or a mother and father might have similar levels of education, right? If you have a more educated mother, it's more likely that the father is also more educated. If you have less education in the father, it's likely the mother also has less education. So there are some X's, when you start putting more and more X, some of those are going to be naturally related. Some have a real connection, and some are just kind of associations, like education, right? There's no rule. You might have one person more educated than the other, like, it's not a rule. Some things might have more of a biological connection. Some things might be a mixture, right? Like maybe you're looking at diabetes and hypertension, right? A lot of times those issues go together, right? There are some mechanisms that connect them, but it's not 100%. But you'll have a correlation. And what happens is when you do that, it affects the regression model. Sometimes it adds more, like, it makes the confidence intervals very big. There's some issues. You can test this. Suppose if you take something that is 100% related, like suppose that the predictor is age in years, you know, and you have 1.2 years, and then you add age in months. So you have like 14 point, right, or something months, exactly the same variable, right? And you just try it in your regression, put it in Stata or SPSS, and the whole thing will just collapse. Because they will say like, well, okay, how do I separate age and age? It's the same thing. How can I give some slope to this and some slope to that? You will confuse the software and it'll just like, it'll, you know, so nothing is usually that extreme, but if you have something like, again, maternal and paternal education, quite related. So that's going to affect the estimates that you get. So what they're just doing is they're saying, I'm adding many things to the model. And after a while, it's possible something is related to something, right? And so I'm just going to check. If that is happening, then I want to know, and they have some criteria. All of these things have no specific rules. Like it's saying I'm calculating something called variance inflation factor, and if it's less than 3, then I'm going to do something. And there are no rules. Some people will use a cutoff of 10. This one uses 3. Like, you know, these are just they're just justifying why you have this model so big. Well, what about linear? You hear that question a lot. And if you ever do a big model like this, like, and you submitted somebody, like some reviewer or something is going to come and say, what about linear? They always do it. So be ready. So that's them saying that they checked. So variables kept significant association in the multivariable regression were considered as associates of nutritional status indicators, C-scores or events of undernutrition. So things that they find are significant, they're considering it. This is an interesting point. So the sampling design of the original survey was taken into account in all analysis, and then they explained how. And this is because this study was one of those national surveys that were multi-stage. So if we were doing the mix data like we were doing, and we wanted to properly account for that structure in the data of province and then village and then household, we would also do something like this to be proper. So they're just explaining that part. So that is the methods. It's a lot of information for very few words, right? It's very tightly written. Any questions on how to read that? It's clear? Is it clear? You guys confused? Satisfied? Okay. Okay, so let's actually look at their result. So I'm just going to look at, I have univariate and I have multivariate. So this was, I think, table 4, and actually this is not the whole table. If I tried to put the whole thing, it would be just like very small. You have the PDF, so we'll look at the PDF. So what they do is, let's just look big picture first, and then I'll go back to details. So they have many, many variables that they're interested in. They try them all. They have household, region, urban, rural, wealth index. They have these things that are like kind of reflecting wealth. So they look at, you know, is the house made of mud or is it made of cement? Do they own land? Yes or no? And notice how they're doing this binary thing, right? They have a reference category and they're using the reference as always no, and they're looking at the effect of yes. So do they own livestock? What is the effect of owning livestock compared to not owning livestock? And then they do that for everything. They do a univariate analysis, so one variable at a time. They have some ORs, they have 95% confidence intervals, they have p-values, and then for some variables that have p of less than 0.10, then those are the ones that go into the multivariable model. So you see here, when we looked at wealth, there was some small p-value here, so all of wealth went into the multivariable. You know, these kinds of things, the p-value was bigger than their cutoff, so they don't move forward. This one, what was it? Oh, sorry, okay. So I'm gonna break your thing. What was significant here? So looking at some of these water and sanitation ones, they had a smaller p-value, they bring it forward and so on. One thing to notice, again, if you look at these are odds ratios, you can see how things are changing. So here's one where the odds ratio was 0.43, right? And then when we bring it forward, the odds ratio becomes 0.74. Right? And now it's no longer significant. It went closer to 1. So closer you get to 1, the less significant you are. Right? Either you're too low or you want to be either low or high. Increase the odds or decrease the odds, right? So some of these numbers change quite a bit. Here's one about sanitation. The odds ratio was, am I reading right, 0.75. And when they put it in the multivariable model, the odds ratio was 1.2. So something's changed, can change a lot. So you have to think about, okay, why is it changing? Did it go from significant to not significant? You know, then what does that mean? Is it because these variables are too related? Well, what, you know, so everything will require a lot of thought, but like, let's just go back to just the original analysis. So I took a small corner so we can talk about this. So I just kept 3 of the first variables. This is the univariate analysis. So each variable, there's a new model, a new logistic regression that you're doing. And so the first one is looking at region, and it's comparing central and east to west. And when we look at odds ratios, and remember, odds ratio is a ratio, something divided by something, something compared to something. So the something is central region of Bhutan compared to western region, right? And then that one had an odds ratio of 1.18. It had a 95% CI. It contains 1. So it's not significant, and in fact, the p-value is very high. Okay. So for logistic regressions, we have some choices, right? We're doing log 1 minus p is equal to theta 0 plus theta 1 x. So that is always what we're interested in, because that number is connecting x to the y that you're interested in. So your null hypothesis, you can write this as beta 1 equal to 0, or you can do the odds ratio, which is e to the beta 1 is equal to 1. Equals. Both of these are okay. So either that slope that you saw, for example, when we did the breastfeeding example, that slope is equal to 0, or the odds ratio is equal to 1. Right now, we're talking about odds ratio, so we're comparing to the number 1. If the confidence interval has number 1, it should be not significant. If it's outside the number 1, it should be significant. Here's an example, right? So we're looking at wealth index, again, in 5 groups. So the poorest, the lowest one, compared to low, to medium, to highest. And here's the odds ratios. So for example, this one, when we are looking at, this is predicting stunting. When we're looking at the odds of stunting, in the wealthiest, the richest people, the wealthiest people, let's say wealthiest, compared to the poorest, the odds of being stunted get multiplied by 0.11, which means it really goes down, right? It's reduced like 90% if you multiply by 0.11. So it's a massive difference in the odds of stunting. And you can see that there's kind of a dose response. This top one is necessarily 1 because this is sort of the reference category. The lowest, the poorest people compared to the poorest people, it's the same, right? So odds should be 1. So that's always kind of by default. Sometimes people put 1 here. Sometimes they just put a dash because it's obvious you compare me to myself, I'm the same, the odds should be 1. Or sometimes they just omit. You can, and that way if your table is too big and you can remove 1 row, or something like that. So you have many choices. And then if you go from the very lowest, most poor people to the next group, actually the odds already is going down. by half. But this is variable and it's not significant, right? But if you look at the effect, this is similar to, again, this is the middle people compared to the poorest. Yeah.
I have a question in the logistic division. Usually we always use the high risk to be referred. Is true or false?
Sorry, say it again.
For the reference, we have to select the higher risk to be the reference or not.
No, you don't have to. You can, yeah, so, okay, I picked the poorest people, the lowest wealth people, right? I could have picked highest.
Because sometimes if we change, for example, if we change to the highest to be 0 and then another to be 1 to 3, and then the odd is also change.
It will change, yes. Yeah, these, so in your software.
And CI also change.
Yeah, of course, yeah. So in your software, there's usually some default, right? You have 5 categories of wealth. They'll probably take the first one as the reference. And, SEDA, the computer doesn't understand, who is the first one. Is it the poorest, the richest, the middle? Like, it just probably puts in like alphabetical order and takes the first one. Or the coding is 1, 2, 3, 4, 5, so it takes the first one, right? So it doesn't understand, it takes in the order that appears in the data. But for you, you might say, I want the reference category to be the wealthiest people. That's fine. It will change your numbers because now you are comparing the poorest to the wealthiest. Before you were comparing to so the numbers have to change. But so yeah, the way I decide is I try to write my results. Like I try to write one sentence, and what you find is sometimes it's easiest to have a certain reference group. Like if it's a yes, no, it's easiest to use the reference to be no, right? Like if it's like, did the child have morbidity? Yes or no? Like sick children have an increased odds of stunting compared to healthy children. Right? Like it's just easy to write, but you can say it the other way, right? Like you can say that healthy children have a decreased odds of stunting compared to sick children. It's also equally true. But you might find it easy to say it in one way or the other. What I would do if you're doing many of these is to do it all in the same way. Like make the reference the one you hypothesize to be maybe more stunting, and then just be consistent, or make the reference to be everything where you expect less stunting, and then just be consistent, because then your writing will be like smoother. It just makes it easier, but you can do any way you like. Yeah.
One more about CI and p-value. We discussed last time with Roger about if in 0 in between this, but p-value should be less than slow by something like that. But I mean this.
Oh, it's not a specific number. The number that you're looking for to be inside the interval is this number in your null hypothesis. So everything here is odds ratio. So the HO is that the odds ratio is equal to 1. So this is why you need to write your null hypothesis. Because your null hypothesis is always going to be like a slope is 0, or odds ratio is 1, or relative risk is 1. And therefore, if that number is 1, then you look for 1. If that number is 0, you look for 0. So because I'm working specifically with odds ratio, I'm looking for the number 1. And in this example, number 1 is over here, right? These numbers are both less than 1. So it doesn't contain 1. It doesn't contain the number of the null hypothesis. It should be significant, and it is. So the p-value and the confidence interval is directly related. Like the formula, if you do the math, it's exactly related. So 95% confidence interval will correspond to that significance level of 0.05. If you have a 99% confidence interval, then it will be related to the significance level of What number? Of what?
High is really big.
If it's 99% CI, it's related to a significance level of 1%, of 0.01. It's always adding to 100. Yeah, 95% will always correspond to that alpha of 0.05, right? So 99 would be 0.01. If you use 90% confidence interval, would be alpha of 0.10, and like that. Okay, I think that is it. I thought we would take a lot of time, but we're like done fast. Any questions?
Okay, I realize it's 2:41, so we'll see if we can spend about 20 minutes talking about case control study. And then hopefully we'll be able to move on. We'll be ready to talk about RCTs in the morning. Okay, so as I mentioned, case control is just slightly less in internal validity than your cohort studies. And it's here on our pyramid of increasing evidence strength, right? Where we have randomized control trial and meta-analyses, systematic review at the top. And when we talk about case control studies, I know you've seen this diagram where we have the outcome or disease. Here with case control, we start with the cases, whoever has the outcome or disease, and the controls, and then we look into the past to see what their exposures may be. And if we have an exposure in mind, we divide our cases and our controls into exposed and unexposed, right? And remind me again, if we have, do we use case control for a rare exposure or a rare outcome? Yes, rare outcome. Why? Very quickly. Why? Why do we use case control for a rare outcome?
We only look back to the exposure and the rare outcome is too difficult to follow up by time.
Right, so we don't want to follow and wait for someone to develop the outcome. We can start with the people with the outcome and then go backwards to look at exposure. So they start with cases of the disease or condition and look for possible exposures. These are really good when you don't know the etiology of a disease or a condition. Do you know what I mean when I say etiology? What causes it biologically or physiologically? What are the causes? Where did it start from? So when we don't know this, a case control study is a great way to try to understand how a disease develops. And also, as we said, rare diseases, which you couldn't really capture in a cohort design. It's also good for diseases that have a very long induction latency period. What does that mean? What is an induction latency period? Anyone? Basically, it just means a long time between when the exposure happens, the exposure occurs, and the outcome happens. Right? So something like, is asbestos a chemical used here? Asbestos, do you know this?
Asbestos, yes.
Yes, asbestos. So asbestos. Sometimes it's in like ceiling tiles or floor tiles, probably not in this building because it's very new. It takes about 30 years between when someone is exposed to asbestos at a amount that's high enough to cause particular cancers. It takes about 30 years. So that is a very long
Let's do cohort.
induction latency period. What's that?
Let's do cohort.
Right, yes, let's do cohort. Might as well, right?
You get my son to service.
Right, yes, exactly. I had a friend actually who, her father was an electrician. And so because he was an electrician, he worked around asbestos fibers a lot. And he would come home from work and have them on his clothing. She was a little girl and would hug her father, and the fibers would get in the house, and she ingested them and got a condition called mesothelioma in her intestinal cavity. So it's cancer, but it's in just the whole cavity of your abdomen. And they think what happened is that she probably swallowed, she probably ingested some of the asbestos fibers when she was 5, 6, 7 years old, and then in her late 30s, she developed this cancer. So that is a long induction latency period. With case control studies, you can also study multiple exposures associated with a single disease. This is another way just of looking at a case control study design. We kind of represent it backwards because when you look this way, this is the way the exposure and the outcome are laid out in actual time, in chronological time. Exposure happens and then the outcome. Pardon me, but our research starts here after the outcome and looks backward. So it still is an observational study design, but here's just another, if you like these representations of the study designs, these are in each of the topic sections for each study design. And it shows you from the population, you have the people who are eligible and not. You separate them into cases and controls. Some people participate, some won't. And then you look for the exposed and unexposed. You group them by exposed and unexposed. What are some ways you can identify cases for a case control study? We've already heard about doing a survey and then identifying who had cases in a year, maybe if you're going to count it that way. And you have a case control. Are you doing a case control for your SRG?
Yes.
And so how are you identifying cases?
We accept criteria, inclusion, it's screening.
Screening at a hospital or
Hospital.
hospital. Okay. What are some, I mean, there's some lists here, but disease registries are a good place. If you have a cancer registry, if you have, if your government has a registry of diseases, you can find cases there as well. Are there other ways to identify cases? A lot of time these will be clinic-based, hospital-based. You'll often identify people through a service provider because they have the documentation that it's a diagnosed case, right? But then you have to think about how you're going to select your controls as well. Do you want all of your cases from the same hospital for a disease? Why might you not want to have all of your cases be from the same hospital or clinic?
It depends on your questions, right? If you measures about the techniques of the clinicians, that might be select only one hospital. But if you measures about the disease, and if you put different hospital, but how about your control hospital? It might be effect to your control progression if you put the different hospital.
That's true. You would absolutely not want to have cases and controls for different hospitals, right?
if you end up selecting cases from one hospital, you should select the controls from the same hospital as well. But also, like Pat said, that if your research question were about the clinicians or the services of that hospital, then that would make sense that you would select cases from that hospital. But broadly, if we wanted to look at outcomes of a disease, we would want to select from multiple different hospitals or clinics because there could be effects by the hospital or clinic. So if we only look at one, we're not going to get enough information potentially. Now, this is an example might be I read a study like this once and I just lost my mind over their selection. And I couldn't believe it got published personally, but they were looking at the outcomes of a particular kind of cancer treatment. And it was a very rare type of cancer, but they were only using cases from one hospital in one city. There were other places that used the same treatment. And I thought, well, you can't, it's fine, you can say how this affects people here in this hospital, but it can't be generalizable outside of that because specifically that hospital was treating the patients. They were treating the cases, right? So any information you might need about how other hospitals or other clinicians would treat people differently is absent, right? And it wasn't trying to be a study about one hospital's way of treating patients. It was trying to make generalizations about this particular treatment. So you need to think carefully about how to select your cases. Now, if there's only one hospital that you can select your cases from, that doesn't mean don't do your study. Of course, you still do it. You need to talk about in your justification why you have all your cases from one hospital and what that might mean for your information. If the hospital doesn't necessarily play a role in the treatment, there may be less impact, but if the hospital only draws on, say, particular population, what if that population only serves people here in Vientiane? How will those people be different from someone with this disease in another part of Lao? Right? So it's possible that you'll see some differences. If you're restricted and limited by resources or ability to select cases, or if everyone with this condition ends up going to this one hospital anyway, it's fine. You need to talk about why. Every choice that's made in your research needs a justification. It needs support and evidence. Does that make sense? It needs to be thoughtful. So you may have a reason for doing these things, but it has to have been a thoughtful choice, and you have to defend that choice, right? Okay, so you can get differential selection bias, unintentionally selecting cases dependent on exposure, or the way that you select cases is somehow tied to exposure status. So you think of a good example of that. Maybe you're selecting cases about a rare kind of, I know I talk about cancer a lot, but that's the area I was trained in. So I think examples come to me in cancer. But there's an area in St. Louis, Missouri, the town I grew up in, where unknown to many people who live there, some radioactive waste was being discharged into a creek that kids played in, that people played in.
many years later, they were finding these clusters of people from this one part of St. Louis developing cancers and also having children with birth defects. So if this were a larger region that we're collecting, or here, let me put it this way. If a hospital where you recruited cases of this particular cancer was in an entirely different part of town, but most people from this area where the exposure was went to a different hospital, will your cases be representing everyone who happens to have this exposure, if the exposure is to this radioactive waste? Right, so maybe it's capturing people who have it from somewhere else. Was not my best example, but if the way you're choosing your cases could be related to the exposure status, then you can have this misclassification, right?
I have questions.
Mm-hmm.
Do you think the case in the hospital is better for selecting case?
Is a hospital better for selecting?
Is hospital better for selecting case? For example, can be compared between hospital, or what do you think for this study?
If you're choosing between, from multiple hospitals, then hospital where case was selected should be a control variable. That needs to be a variable that comes into your regressions, right? So because there may be effects of that variable of hospital where you selected cases or controls on your relationship.
Because in my study, the diabetes study, we have really 3 hospitals, and each hospital we have 6 groups. We say maybe just only 2 groups, control and uncontrol diabetes for each hospital. And do we think we can combine that for this control? We have to compare the hospital. But for now, we have 3 simple hospitals that have different system of consultation.
Different system of consultation, did you say?
For the yes, for the outpatient.
So you're saying you're selecting the cases and the controls from the same hospital, but another group from a different?
We all the patient is diabetes patient, but we compare between patient with control status, and in control status that high or not high. It is hospital.
So you have controlled status, controlled diabetes, like diabetes is controlled or uncontrolled?
Yes. And all the time if they're consented, we will enroll them.
You'll enroll them if they consent. But are they all coming from the same hospital or no?
Come from the same hospital, 3 hospitals that we have.
You're collecting data from 3 hospitals.
Yes.
That everybody, I'm not sure the
I
question.
have question for her.
Okay,
I want to know the study design. Is this cohort study or is this case control study? Or is it
That is conceptual, but we can go as control as well, because before this I used to think about case control as well. But case control should be one that this and this.
but diabetes is not a rare disease.
But if I would like to decide to do this.
it's not as much a rare disease, no. I mean, you don't have to only do it with a rare disease. You could do diabetic cases and controls and go back and look at exposures, but I don't know what your research question is, so I can't say whether that research, the design of case control is appropriate. But I'm still trying to figure out what is the question that you're asking though?
Daily pattern, this daily pattern is associated with diverse status, but that study we use for positive. But before this decision, I used to thinking about this control before.
I see. So you're doing a cross-sectional study. But what you're saying is you thought about doing it as a case control study
Yes.
and selecting people with diabetes, people without, or people controlled.
And diabetes in control.
Okay, but what's your research question?
This daily pattern is associated with
If dietary patterns associated with not having diabetes, having uncontrolled diabetes, or having controlled diabetes. Okay. I just I keep thinking I'm talking to it. Okay, is dietary behavior associated?
Yes, and we also
First, one question is, isn't this, that's something that's pretty well established in the literature, right? Dietary behavior
yes.
and diabetes status. So what is your study adding? What are you looking to understand in your study that hasn't already been published in the literature?
They said that people who have dietary is the food that we taking is molecular risk factor that we can change. So if we change to healthy food, the status can be improved.
Right.
If there is not healthy food, like the food that have the ultra processed food or high in sugar, this can be worse. This can be
Okay. So are you looking at the specific types of food? I'm still just trying to understand what is different about your study than what we already know about dietary intake and diabetes.
We try to keep the food quality that they consume.
So you're looking, okay.
Like, for example, if you recommend and eat for food every day, for example, if the Christian eat for food every day or one food that they eat a lot, and what is missing. How can I actually put it in control?
Yeah. I don't know, I mean, I don't think it would work as a case control study because, no, I mean, it's a pretty well established relationship. It sounds like maybe you're just trying to understand a little more nuance or detail about the exact types of foods and the diabetes outcome. Or are you using like a different method of measuring it? Yeah, but I don't think it would work as a case control study. Yeah, it looks like, I mean, yes, it seems like maybe it could be, again, like there are so many details that I don't know. But if you had, depending on how you're measuring diabetes, controlled or uncontrolled, and not having it, and whether you're looking at any kind of change in that, or if you're just trying to understand at one point in time whether these foods are associated with this diabetes status. So there's a lot of, I have a lot of questions about like all the details of it, but yeah, it's kind of hard. It's kind of hard to say. It sounds like it's kind of a descriptive assessment of what people with these different levels of diabetes are currently consuming, right? Like a bit, is it just and is it just that day? Like it's a survey, or you just ask them about what they ate
that day or? Yeah, yeah. Yeah, I mean, that could give you some good information about like what right now are people in these different groups consuming. Yeah.
Maybe it is because when we decide about like the cross-sectional study, and if we would like to continue like case control, but I think if we select like a book and the patient come and we make tree of hospital and we classify severe and non-severe like this. Maybe we look at back and take at one look later, but if they got if they have the rate already, but we select on disease, only disease, we didn't have control, right?
Yeah.
But how we measure and how we identify if we think about its content. Something
Yeah.
like that.
Well, and also I can't imagine having dietary practices or habits as your exposure group for a case control study, because people don't remember that. Like you really can't go very far back in time. I can't tell you what I ate yesterday much. Yeah, so I don't think that a case control study, I can't imagine, I don't think a case control study would really ever be a good, as with dietary habits, as an exposure would ever be really a good idea. There might be certain things, like if you're asking a mother if she gave a certain nutrient supplement, but even then you need to keep it within a pretty short time frame. Case control studies, when you're looking for exposures, I mean, this is part of the problem. If your exposure is not memorable or something you can find in records, it's going to be really hard to do your case control study. So this is actually a good point that we can kind of end on, is that you're doing a case control study when you're looking for things that are really going to kind of stand out, because you have to rely on people's memories, or you have to be able to access old medical records, occupational records. Maybe if you're looking for an occupational exposure and you know that they worked somewhere at a period of time, and you can look at that factory's practices around protection from chemicals. So you aren't going to look at just regular everyday behaviors with a case control study as exposures, because they're not memorable. And it's gonna set you up for failure. So don't do that. Case control studies really are looking about this, and we're talking about a longer latency period. You know, you may do something, I don't know, maybe about like, if a person can remember like the foods they ate most in their childhood and diabetes. I can't think of a good way or example of using case control study for dietary behaviors. It would have to be different, like was baby breastfed, and then 30 years later, did they develop some outcome? That's reasonable, because it's probably going to be a yes or no. That mom may not remember for how long, but you have to be able to accurately and precisely measure your exposure, just as much as you have to be able to accurately and precisely measure your outcome. Okay. Preferably with the supplement of something like physical records, medical records, occupational records, vaccination records, something that's going to tell you that this exposure happened. Okay, so it's after 3 and it's 3:10. So technically you all are free to go. and we can pick up with this tomorrow,
But
unless you want me to talk longer. But I don't want to cover anything if people want to go, because I don't want to miss anyone. Do you want me to, do you want to stop, or do you want me to talk until 3:30?
yeah, another 30 minutes, great.
Okay, okay, all right. Okay, I like this. I like this can-do attitude. All right. So we'll go to 3:30. Okay, so one of the, well, I'm going to come back to this slide. I'm going to go to this slide because this is what we we're just talking about. Having the standard definition for exposure and outcome, and preferably objective markers of the exposure. So if you can have some kind of blood marker, physiologic marker, something that lets you know that a person was exposed, maybe it's an antibody to a virus, I don't know. If you have some objective marker, that, or like I said, a medical or other records, you can use observation and self-report data, but you're going to have more error, potential for error in self-report data, right? You can also, yes, train observers or interviewers to obtain data. So you have to make sure you're training everyone the same. But if you have trained a team of people on your study to go and look at each person's medical records, in your cases and controls, and look for certain exposures, you have to make sure they are well trained to look for that exact exposure, right? You don't want somebody to miss something. And you can use a blinding process. So you could train your interviewers to go look for the exposures among cases and controls, and they may not know whether that person is a case or control, the person whose record they're looking at. That would be ideal, because you never know how bias slips in. Interviewer bias and data collection bias is a real threat to the internal validity of your study, and it happens all the time. I don't know, I can't remember if I talked about this before, but I worked with somebody who was a part of a study where the PI, the investigator, had decided that he would compensate his interviewers by interview completed. What might be an issue with that? So you hire interviewers to collect data. They have to interview respondents, and they are paid by interview. They might go very fast. Yes. So they can get more money in. What else?
Yes, and then maybe answer quickly, like don't think about is reliable or not, just.
Yep, so they might have people sort of rush through and answer quickly. What else?
Quality of data collection.
Say it again.
Quality of data.
The quality of data collection, yep, yeah. They might fake interviews, right? Yes.
Mandatory survey.
Yeah, right? Make it up. So that is a terrible practice. A terrible practice. Don't pay your data collectors by interview. And I hate to say, but this person, it was the dean of research at a particular school. Mind-blowing, but you can't do that. That's gonna bias. And so my friend who worked on the study was like, I've tried to let people know that the results of this, we don't know if they're valid at all. because we're paying people by interview. Okay, so just make sure that you are training everyone. Recall bias. This is a real issue in case control studies, because if you have a rare disease, what do you think that means for whether you are more or less likely to recall being exposed to different kinds of exposures? Okay, if you have a rare disease, if you have something that many people don't have, how might you think about possible exposures that could have caused the disease? Say it again. You think less? Or
for example, like polio.
okay, but so imagine that you yourself come down with some strange disease that you don't maybe know a lot about. And do you think you're going to think more or less about ways that you may have been exposed to something that caused the disease?
Not all exposure, but in around time the important by the result. Prioritize the exposure.
Prioritize exposure. So I don't know about any of you, but I have all kinds of weird things, and I'm constantly thinking about why I might have these weird things, right? I'm like, well, maybe it's because I don't know, only ate salami when I was a kid. You know, like maybe it's because of this. So often people who have a disease that they're not entirely sure how it was caused are going to be thinking a lot about the possible different ways they could have been exposed to something. They might be like, no, yes, I think in third grade that I might have stabbed myself in the hand with a lead pencil and the lead broke off and I have lead in my hand. And maybe that lead caused this disease, right? That true story. You never know. But people who've maybe never even thought about or heard about this disease, they may not be thinking, they may not have spent time thinking about their past and trying to understand how they may have gotten this disease. Right? So how will that affect, how will recall bias, we call this recall bias, what will that do? What will happen? So what might be, we know the cases and controls, but what might be misclassified?
Example, eating recall, like then we ask for yesterday, 3 days, 1 week, maybe this is okay, but 1 month or half a year is recall, whereas I cannot remember.
Well, but for a lot of case control studies, you're asking people about exposures for their whole lives, right? So what will happen is that it's possible people with the disease will have spent more time thinking about this and will list many more exposures, and that there'll be controls who never had the disease, who may have experienced these same exposures but don't remember it because they just haven't spent that much time thinking about it. So it's definitely, you can solve this by having more concrete markers of exposure or looking in records, but sometimes you just have to ask people. And so realizing that you may have some exposed people in your unexposed group because maybe they don't remember. But that's more likely to happen in your controls than in your cases, okay? And that can result in this differential misclassification. So if your information is essentially better in one group than another, then it's like we talked about on the board the other day where your effect size could be smaller. That's what can happen with your differential misclassification. Okay. So one issue in case control studies is that we can't rule out entirely reverse causality. What do I mean by that?
Based on the theory or the mechanisms of the disease, because that we cannot answer the whole of the field of the animal. For example, like lung cancer, that's from the theory, they might not have lung cancers and for someone that they smoke. But for some disease that we know exactly that if they expose to the exposure for the 10 years or 20 years and the results might not come, that would be help them to think about their thing that for example, like you expose to the what we in the 10 years how many times.
Yeah, if you're exposed to what over 10 years?
Flooding.
Flooding? No, sorry, what? Yes?
Yeah.
Flooding.
Yeah.
Yes. Ah, I see you're taking a real life experience example, aren't you? And you don't remember if you've done, yes, right? Because you were saying people don't really remember some of these instances. It's very true that people's memory, people's individual memory can be a very difficult thing to rely on because people don't remember and people remember things wrong. That is very true. So we can't always know when that exposure happened in relation to the outcome, even though we're starting with the outcome, right? If we're only asking about an exposure that would have happened 20 years ago, we have a better sense of the time, but we can't with absolute certainty say that this exposure came before this outcome. We can only say that in a cohort study where people are not diseased at baseline and they develop the disease. So even though case control gives us a sense of a temporality between exposure and outcome, we can't actually calculate risk or probability because it isn't what is it that we calculate that gives us risk or probability of a disease or outcome in a case control study?
Yes,
What do we calculate in a cohort, I'm asking?
We discussed about the relative risk and odds because that we think that for the case control we might get it on.
Right, yes.
Right.
Risk,
Not,
yes.
not a relative.
But so in a case control study, we calculate relative risk. What's that made up of? Huh? What's on top? What's on bottom?
Relative is that the exposure.
What about the exposure?
Disease.
The what?
Case of disease or exposures.
Cases of the disease among the exposed. So what's that called?
Incident.
Yeah, the cumulative incidence.
Cumulative incident of exposures and cumulative incident of unexposure.
Right, okay, yes.
Give her some pets.
Oh, yes, you get another pen. There's another pen.
Pets will give me.
Ah,
Who will teach me my Pepsi?
ah, one Pepsi. Okay, yes.
Wow.
So this is great, but this tells us this is risk, right? This is the probability of developing the disease because we're calculating the incidence, the cumulative incidence, because we are starting with all people who do not have the disease but are at risk, and we're watching people develop the disease over time. That's a cohort, right? In case control, we're not doing that. We cannot calculate this risk or probability of a risk because we're starting with the disease. We're starting with the disease. So we can't calculate probability, risk or probability. But we do calculate, like you said, the odds. Okay, and I'm going to talk about that in the next slide. 3 minutes. So for this essentially is going over what some of the biases are. I think that we've talked about this choosing, so identifying your cases and selection of your cases and controls, representative controls. There are often you do matching in case control studies where you match cases and controls on as many similar characteristics as you can. That's one way of doing matching that can work really well if you have a lot of people. Which type? Yeah, you can go through which type of matching you're going to use. Making sure that you have a really good way of assessing your exposure and outcome and your covariates, training your data collectors, protocol, training. And then these different types of bias, selection, recall is a really big issue in this. Misclassification also, that's related to the recall bias, right? And so we tend to think that the data quality isn't all as good in case control as in some other studies because of this reliance upon reporting the exposure or finding the exposure, but only a little. This is not like, don't anybody walk around being like, well, a cohort is way better than a case control study, right? Like they're pretty close. And then you can't measure risk and you can't technically establish this temporality. So I think that tomorrow morning, we'll start with talking about, did I just hear a sigh of relief? Calculating odds ratios. Oh, did you just get excited?
No, yes, I said that, before the slide you show us before, but not, like the, yeah, this slide.
This, yes.
Yeah.
I have the same interpretation, the same sentence for interpretation for your case control studies.
Yes.
Actually, and I'll talk about this quickly and then tomorrow we can do an example. So you're looking at the exposure odds ratio is your measure of association. Most people use a multivariate regression or a logit. You cannot measure incidence, so there's no measure of risk. But our hypothesis for a case control study is if the exposure, this EOR is exposure odds ratio, right? There's no difference in the odds of exposure in the cases and in controls. That's our null hypothesis. So our alternative hypothesis is what? Yes. Exactly, that there is a difference in the odds of exposure in cases versus controls. And so we don't want our exposure odds ratio to be 1, or we do because then there's less trouble, right? But like with cohort studies, where we are going this way to look at our exposed, the diseased among the exposed and the diseased among the unexposed. For case control, we're looking at what?
exit the order of the cases and controls.
It's
The order of the
No,
exposed.
we do the case exposure and non-exposure.
yeah, so it's the, yes, the odds that a case was exposed versus the odds that a control was exposed. So we have our disease outcome. So we want to know, what are the odds that people with the disease had the exposure? And what are the odds that people without the disease had the exposure? Okay? So, go.
That exposed.
Yes, so this is called an exposure odds ratio. So what you're looking at is you've got your diseased and you're not diseased. That's your cases and controls. You want to know how the odds of being exposed in your diseased group compares to the odds of being exposed in your control group. Because you're not looking at what are the chances of developing this disease, right? You already have it. You've got the people who have it and the people who don't. What you really want to know, what are the odds of having had this, whatever the exposure is, of having, worked with this particular chemical or asbestos, or smoked 20 packs a day, or drank 20 beer Lao in a day. I don't know. I don't know what's a reasonable amount of drinking, right? That's a lot, right? I mean, that's still a lot. 20 beer Lao one day, I think. Right, okay, I'm just checking to make sure you're still awake, right? Okay, so you don't have the denominator of a total number of people, right? You have this, again, it's A over C over B over D. So should I do this now or wait? Till tomorrow? Do it now, do it now. Yes, got it. I am here to serve and I am happy to do so.
If you not continue tomorrow, you will start at the beginning again.
Yeah, I know, exactly. Okay, so, the exposure odds ratio, somebody let's use an example. Someone give me an example of what might be our disease here and our exposure. Here.
Indianauniversity or maybe spinal cord cancer.
Something with cancer? I was gonna see if I had like a example. It's all smoking and lung cancer, which I know is so boring, but it's one of the few things that we just absolutely know.
Low birth weight.
What?
Low birth weight.
Low birth weight and
And the exposure might be maternal infection.
maternal infection.
Pregnancy, infection during pregnancy.
Okay, all right, so does everyone agree on this? Does this seem like a reasonable? Okay, can I do LBW as low birth weight?
Yes.
All right, and can I just do this minus,
Yes.
or do you want me to put controls?
It's
It's okay, all right, and then,
Sometimes minus is good.
what'd you say?
Minus is also good. Sometimes.
That's true, that's true. Okay, so maternal, I'm gonna do infection, that's my abbreviation. Okay, and I'm just gonna do this, no
No pregnancy.
maternal infection
I'm still gonna put a minus here. Okay, we expect low birth weight to happen more with people who have maternal infection?
Yeah.
Okay, all right, I just want to make sure we put some realistic numbers here, right? Okay, so let's say the people with maternal infection and low birth weight, we're just gonna go with 50. Those who had low birth weight but did not have a maternal infection. Yeah, reading my mind over here. Okay, people who had a maternal infection but did not have low birth weight. I love this collective guessing. And then no maternal infection and no low birth weight, that would probably be the biggest, right? So let's go with like 80. Right?
Whatever.
Because this is gonna be like your standard people, right? Maybe?
Oh, now it has a suggestion, should be equal number of some.
Yes, and control is not the same number.
Oh,
That's what you find out.
you are so right. Thank you, nice catch. Hold on, I'm just gonna write this. It's a case control study, we've started the same number of cases and controls.
48.
Really good, okay.
Maybe
So this will be,
in a lower weight about 25 in that maternal, 25 and 45.
okay,
25.
maybe we'll make this even smaller. We'll go like 10 and
60.
70. Okay. That was my,
Good calculation.
does this seem okay? Thanks.
It should be okay.
Yes.
All right. This is, I'll tell you what, when you're teaching, this is some of the hardest part is either, finding a study that can give you these example numbers. Or, I mean, you all are professionals, so you can make some estimates about this, but your students won't, probably, right? So you do, like, sometimes you have to spend a little time thinking about these examples in advance to have numbers that make sense. I just rely on you all, because you're so smart, so, okay. So our exposure odds ratio is, yes, odds. Cases were exposed, is that what it says?
Yeah.
Mm-hmm. Over the odds controls. Okay, so the odds of the cases,
50.
Times 0 over 20.
70.
well, let's first do it this way, right? Let's do our A over C and our B, actually, I'm gonna write that first, hold on, just. Because A over C, B over D, just so that we're taking every step. Okay, so now what are the numbers?
50.
Over.
20. 20 over 60 over.
Okay. All right, so how do we solve for this? It's easier to do A times D over B times C, right?
C. Yes.
Okay,
Yes.
so
50.
50 times 60, is this right?
Yes.
Okay, so what do we have now?
300. Yes, correct. Over.
Maybe yes.
Yeah,
3,000.
yes, 3,000, I was gonna say, there's no way.
Yeah.
50 times 50.
That's seriously.
Yeah. I'm going to sleep at. It's pretty under here.
EOR 15.
Is this 2,000? Or is this just 200?
That's correct. That's correct. Yeah, that's correct.
Yeah, no, I know, yeah, this is correct. So it's 3,000 over 200, right? Okay, so then I just don't bring this back to the middle.
Oh, 15.
Here, we just do.
I will not belong in that group.
You're looking at in this group?
No,
No.
I am.
Yeah, you're like, okay, so, hold on.
Yes.
How do we describe this? How do we interpret this exposure odds ratio? Okay,
In the list.
but let's use what were the odds of maternal infection
If the low birth weight group
in the low birth weight group.
were 15 times greater than the
Then
odds of maternal
infection.
not maternal infection.
No, you still say the exposure of maternal infection in
In the normal
the
weight group.
normal birth weight group, right? So the odds of maternal infection in the women who had low birth weight babies were 15 times greater than the odds of maternal infection in women who had normal birth weight babies.
Odds of 15 times greater than the odds of mother who haven't got infection.
No, it's still the exposure. It's still the odds of the exposure, right? So basically, what you're saying is the odds of having this maternal infection is way higher among those who have low birth weight babies than the odds of having a maternal infection in the women who have regular birth weight babies. And that is what can trip you up. But you're not talking about, you're comparing the exposure. You're comparing the exposure between the cases and the controls. What are the odds of being exposed or having the exposure if you're a case versus when you're a control?
So that's why the OR is the odds of exposure.
That's why it's called the exposure OR. The EOR, the exposure OR.
In
Okay.
control.
All right. I'm gonna write that sentence here, okay? And that's huge. That is a huge number, 15. We did a very good job in our little estimates here to make that a trial stopping odds ratio, right? I mean, it's very big. Okay, I'm just gonna write out the full sentence here, but otherwise, do we have questions on this right now? Do we want to do some more examples of calculating risk ratios and odds ratios? We're gonna do RCTs tomorrow, and the next unit, the topic is on measures of association, so we can do more practice on calculating the different measures of association and the determinants of causality, how to use those to determine or infer causality. Yeah. Okay, so I'm gonna write this. You've all been just wonderfully awesome today. I mean, you're wonderfully awesome every day. But this has been a really fun day. It was delightful to watch you all teach and to see how good all of you are at teaching. Really, this has just been really fun, and I wish we had another week. Although my kids would probably personally come here and drag me away.
Dubai Asman well, you know, PowerPoint inside of it.
Okay, and so tomorrow, the plan is, I'm gonna save this kind of system science exercise for maybe November or another time. Oh, your face fell. But because I really want to make sure we finish talking about study designs and measure the causality and measures of association tomorrow, okay? And I'm hoping maybe in November or another time, we can talk a little more about some of the practical implementation of research projects that are in with the building protocols and trainings, and to talk more about some kind of behavioral aspects and other aspects, but that is to be determined for this year 5, right? Yeah.
But all of module 5, 6, and 7, the main difficult part we already explained.
I think so. Yeah, I think once we get through tomorrow morning, we'll have most of, and so what we'll probably do, we were saying that with a little bit of break, but just go through the morning and maybe lunch also, like we'll eat lunch, but then we'll end at 1, I think 1, we said 1 p.m. Is everybody okay?
And after your lecture, I will correct Lao version. Because before that, I study long time ago, I forget. And now I listen your explanation. So Lao PowerPoint needs to be correct some.
Okay.
But I will do.
Yes.
Because I check English and Lao.
That sounds good. And I'll give the slides with the incidence and prevalence, because those were separate.
This morning very clear to understand for
Yes.
incident and also ratio and also rate.
Yes.
Option. Yeah.
Okay, I'll put
Maybe
those.
good example for maybe we will translate this into Lao as well.
Okay.
To insert some PowerPoint in module.
Yes. Yes, like we now have like supplementary
That's nice.
topics. And I pulled those from a few presentations, so I'll put them together into one.